My name is Wendy Kaiser-Philander, the chairperson of the Standing Committee for Health. Today is Wednesday, the 17th of November, 2021, and the committee will be deliberating on the annual report for the Western Cape Department of Health, 2020-2021. I wish to welcome all honourable members, as well as the Minister, the HOD, and all department officials. We do quorate as a committee with 3 permanent members present, so we will proceed with the meeting this morning. I will now duly ask members present to introduce themselves, and then we will go to the Minister, the HOD, and the rest of the departmental team. Before we do that, can I please ask the committee to, if we can perhaps just observe a moment of silence. I think it is just the right thing to do this morning, and thinking and reflecting of our healthcare workers that succumbed and those that are still struggling with this pandemic. Can I please ask you to rise for a moment of silence, please? Thank you very much. Can I kindly ask that members introduce themselves?
Good morning, everybody. Lorraine Botha.
Goeiemôre, Regan Allen.
Thank you very much.
Remember how to press, where to press. Morning, Bombo, no, my friends, Paul Calhead for her.
Good morning, Chairperson. Keith Clutie, the head of the Health Department. And I'm going to ask the team members to very quickly introduce themselves. Thank you.
Sure.
Morning, Chairperson. Sadiq Karim, Chief of Operations.
Morning, Chair members, Minister HOD, Simon Kay. I'm the Chief Financial Officer. Yes, that's what I am today.
Good morning, Madam Chair and members. It's Dr. Krish Vallabhji, Chief Director Strategy.
Morning, Madam Chair and members. Andre Lack, People Development.
Morning, Chairperson. Peter Smith, HR.
Morning, members. Rehana Shade, Director People Strategy.
Good morning, members. Eugenia Sidumo. I'm the Acting Chief Director for the Rural Health Services. Thank you.
Morning, members. I'm Dr. Mkosi. I'm the CEO of Tigerberg Hospital.
Morning, honorable members. My name is Nonhlanhla Andankosi. I'm the Chief Director of Financial Management. Thank you.
Good morning, Chairperson and member. I'm Laura Angeletti Dutwe, Chief Director, Facilities Infrastructure Management.
Good morning, members. I'm Akona Stemele, Community Outreach Officer, Office of the Ministry. Thanks.
Good morning, members. I am Noma Wetus Pugwana, the spokesperson for the Western Cape Health MEC, Dr. Noma French Mbombo.
Thank you very much. Members, just for the record, we have not received any apologies. I see members arriving. Members, can you kindly introduce yourselves?
Good morning, Chair and everyone. My name is Rachel van Vogel.
Good morning, Chair. Good morning to the department and everyone. My name is Ayanda Barnes.
Thank you very much for joining us, members. And Member Tego also just indicated that he will join us online. I do not observe any members of the public this morning, although this is a fully fledged public hearing.
Thank you, Chair. Sorry, Chair, I'm here. Thanks.
Member Tego, thank you very much. We note you and we record such accordingly. Good morning, member. Can you kindly introduce yourself?
Thanks, Chair. It's Member Kako. Thank you very much.
Welcome, member. Member Bakufos. Will you please just introduce yourself for the record? Welcome. Thank you, member. Members, the annual report monitors the Department of Health's performance for the 2021 financial year, as you know, against predetermined annual targets as outlined in the 2021 annual performance plan. Members, I will now hand over, or rather, let me just quickly share the House rules with you this morning. We will be dealing with the annual report by section, of which you know section part A, as per the documentation that you have received, are pages 9 to 25. So which means is when we deal with part A, members then kindly refer to the designated page once posing their questions, as well as for part B, pages 29 to 90. Part C is the governance part on page 101 to 112. Members, this section will also be dealt with by SCOPA, but members are allowed to ask questions and just indicate the page number. Part D, which is the human resource management, pages 117 to 128, and Part E will then be dealt with at 2 o'clock at SCOPA, pages 159 to 166. Members, can I please kindly ask that we practice due discipline in keeping to the business of the day, and please refer to the pages at the allocated section of the annual report. We will also be taking a tea or a body break at 10:30 to 11 o'clock. And members, I'm sure that we will be able to wrap today up at 1 o'clock sharp, after which members will then receive a lunch. And I do ask that you kindly adhere to COVID protocols. And members, I'm sure that we would be able to deal with our business within the allocated time frame in order for us not to come back after SCOPA to conclude this meeting, please. Thank you very much. Are there any questions for clarity at this stage, members? None noted. Thank you very much. So we are all in agreement. I will now hand over to the Minister of Health to give us a brief overview and her remarks on the annual report, after which the HOD then may proceed with his input, and then we will go over to the question and answer session. Thank you very much for being here, Minister.
Good morning, everyone. Goeiemorgen. It's good to be back. The last time I was here, it was, I think, in Feb 2020. So I'm reorientating myself. Thank you, Chair, for giving us the opportunity, and also for the team that will do the presentation. I won't be talking on the forward, because there will be questions that are going to be asked around then, but just as a preamble, this budget here that we're presenting now in terms of the annual report is from the 1st of April 2020 to the 31st of March 2021. This is the COVID year, and this is the year where we saw things in the whole South Africa, where things changed, not only the health system, but in the whole country in regard to the lockdowns. Specifically, that's when we had also the lockdown level 5. This is also the year where we have seen as many healthcare workers not only got infected, but who died, specifically in the second wave, which is also part of the year. Also, you may recall that with vaccination, we only started with the Sisonke project on the 17th of Feb. For the then the other ones, which is the senior citizens, it's only started, I think, 17th of May. So when the year ended, we only had 1 month after we started with the vaccination. So, Chair, if I just to highlight, I want to use that phrase of the movie, the good, the bad, and the ugly. But I want to start with the bad, the ugly, and the good. So the bad part, it says indicated, is about that's when we're affected as the health system mostly, but also all other social ills, which is the gender-based violence that was happening in the other spaces, private spaces, the alcohol that was happening, abuse in the other spaces, the unemployment that was happening in other spaces. We have to absorb those. Also the bed, it's about when we have to decongregate the system, where we have to prioritize the pandemic, meaning that many other people have been affected. So it meant that we have to do things differently. Affected in the sense that even with the elective surgeries that we have to delay. And also about now when we limit the traffic or the people coming to visit the hospitals for their loved ones. And then as a health worker, we have to balance where you become a healthcare worker, plus also the social aspect of giving the emotional support to some of those people. It is the year when we, specifically around the third wave, the moral injury that was being, that affected the healthcare workers, when we have to decide which one we have to give the ventilator, which one that we cannot give the ventilator. It is the year where you find that even, I remember, I think, I'm not sure it was a Christmas Eve or New Year's Eve, Dr. Klute, where all of us were just waiting, waiting for the truck that was supposed to come with the oxygen when it was about, at the time, if that truck couldn't arrive, it meant that we'll end up not having oxygen, which is actually, it was affecting also in other parts, not only Western Cape, but already we had to even to borrow each other with a private when also they even had no oxygen. It is the year where also we have lost many of us, not only from the COVID, but also from the time that some of us have to retire, like Dr. Engelbrecht, the CFO, Mr. Van Niekerk, and also the others. I think it's also part of the report. So that is part of the bad. The ugly part, it's where for the first time as a health system, we end up being questioned, especially the clinicians. When someone is diagnosed, let's say of diabetes, and then you say, take this pill and take that and do this. Most people say that they'll trust that doctor or whoever that health professional providing those advice. It's a time where you'll find that when they go to the hospital, when you say, take this oxygen and all of those, where they rely and trust us. But the bad, the ugly part, it was about when people from a plumber, from the security, they will question the COVID and also the interventions. So you have to balance with the whole things about the fake news and also people who actually perpetuate all these incorrect kind of the measures. It is the year where in history, I know with the HIV/AIDS, but this one was worse, where it was so politicized because it was affecting everyone, being questioned as a health system, but also the whole lot of political parties use it as a football tool to attack one another. But also the ugly is about, it's a year when the PPEs that we needed for everyone in some other parts of the world, of the country, were being stolen. And it's a year where actually we needed as many resources that were required. The good part is about the lessons learned from our side in regard to doing things differently. It is the year where, for the first time, the working relationship between the public and the private, because when we're working around the beds, we could be able to count to say that with the critical care or ICU beds, we know that in the public, there will always be a shortage. But we reliably have got so many beds in the space of the private. Also in that space, it's about when the private says that we can't take any other non-COVID patients anymore, those patients now are gonna come to you. We say that at the end, they are also human beings. It's a space where we work closely with civil society, NGOs, even through community health workers, to dish out packages of medicines, even for the 2 months period. We rely even in the community health workers, not only for the screening, but also even in regard to the dispensing of these medications. The good part is also it's a year where we work very closely with the university, and we also reiterate the importance of the evidence-based led interventions, up to where no one would have thought that we could be able not only to build a hospital, 800 and plus bed hospital within a month, but also even to have a dashboard where you could be able to have all these cases and everything under one roof, without even consulting the other, the consultants, but it's being built within, which also made us to win as many prizes. It is also the good part. It's about the agility of the health system, where also anywhere you go to Maritzburg towards that end, and then you go to even to Morsfley in the Matsikama, where each and every healthcare worker will find that they are in it. In as much as that we got affected in terms of the COVID pandemic that affected us. But it was about, we are here, we are not staying home, we are here to work because we want it. In as much as that we received as many of them, as I indicated in the ugly, of the many of the people who were actually fighting and all of those. So, Chair, having said that, we also realized that towards the end, before we had the third wave, that there are many other interventions that were required, that there was no way that we can compromise on them, in as much as that we decongregated the system. For example, the immunizations, the HIV, that's when we had the Vulumpilo campaign, and also it was the time that the social sector with the disability grants for their medical people that needs to assess them, we ended up assisting them to absorb them as part of the Vulumpilo. But I think that also the best part is about, in as much as that we decongregated, but specifically in the rural areas, the immunizations and all of these packages that are very crucial, where they could end up having dire consequences if those were leaving them behind, like the immunization, the first, the HIV testing and the first treatment, also for the TB and all of those, that we never dropped. Because it's still, if you look at the data, you'll find that we still continued rendering the mobile clinics, in as much as that we have to limit all of those. But lastly, it's a year when you reflect on it, you find that we don't want any other time. We don't want to go back there. It was a really hard year. In as much as that we have lessons learned, but it brought us all close to together, and that we even have a clean audit. It's still amazing that under the circumstances, we could be able where we are. Thank you very much.
Thank you so much, Minister, for that very extensive and open and honest reflection. It really took us back. Thank you so much. HOD, Dr. Klute.
Thank you very much, Chairperson, and to all the honourable members. It is indeed for me a privilege as the first time as the accounting officer for the organisation, to be able to table an annual report in this House. And in our preparation, as the Minister said, we went through what the compilation of the annual report was, and we relived the story in the pages of this annual report we put in front of you. But for me, it was a story of humanity. And I really would like to take the time to acknowledge every single person in this House, because every single person was affected personally by COVID. I also want to acknowledge every single person of the management team in this room, of how incredibly proud I am to be the senior leader of this team that works collaboratively and we take collective decision making. And the 34,000 staff members that is out in the field. It is an incredible privilege to be able to table an annual report on their behalf to the people of the Western Cape. On that story for me, because of the personal trauma that every single person has experienced, and their family members, and work colleagues, and people from the broader society, in the face of let's call it adversity, I believe the best of humanity comes to the fore. So I would like to believe what we've learned in this period is to be kind, to be human, and to be taking our job serious of looking out for the other person, especially the one that's most vulnerable and that's most in need of our care. That's reconnected us as a healthcare system to our core purpose. The reason why we are serving the people of the Western Cape is to serve the person that is the most vulnerable, the one that has the least. And in the moment of vulnerability, they need our kindness and our care. So for me, and on behalf of this team of people here, I really want to say that as a team, we've connected to that reality. It's connected us to our purpose. We're serving a purpose much bigger than any individual person's ego or status or whatever we want to call it. And we are humbled by the fact that we called to duty to serve the people of the Western Cape in this time. Because for us, it's something bigger than any individual person here. So we humbly stand in front of you as people serving the people of the Western Cape humbly. And therefore, in your oversight role, we also welcome the fact that we subject ourselves humbly to the oversight role of this. We've learned the power and the respect of institutions in this year. So the minister rightfully said, while we had to do what we had to do, we had to respect the oversight role of every oversight entity that we've come across. It happens to be the year that we've probably met the Auditor General more than anybody else. It happens to be the year that we've had to deal with the Human Rights Commission, and we had to connect with the Human Rights Commission, the Public Service Commissioner, with the Public Protector. And the fact is, all of those entities have an important role to play in terms of oversight. So we proudly subject ourselves to that oversight. We believe that if you have a healthcare system, we would want to believe that the people of the Western Cape have trust in us. We would like to believe that the oversight bodies keep us accountable so that people's trust are is affirmed through this. But similarly, we would like to believe that our own healthcare workers feel proud to work in an organization like this. And we would like to believe that the patient that's served us feels proud to be served by the public health system in the Western Cape. So in that humility, Chairperson, we submit to you the content of this document. And as you know, I read these words of the statement, which for me is quite important because I have to sign as an accounting officer. To the best of my belief and my knowledge, that all this information that we disclose to you is consistent, it is complete, it's accurate, it's free from admissions, but very importantly, it's done from the basis that we are committed to an ethical code. And that's an ethical code to serve selflessly and not for personal gain. So in that sense, thank you very much for giving us the opportunity to account for our actions of the year. Thank you.
Thank you very much, Dr. Klute. I will now ask members whether they have any questions pertaining to the minister's input as well as the HOD's input at this stage. I recognize Member Windvogel. That seems to be the only hand. Okay, after Member Windvogel, it will be Member Allen and then Member Botha, in that order. Thank you.
Thank you, Chairperson. Chairperson, allow me to just apologize for being late.
Excuse me, Member Windvogel, may I just ask that you speak into the mic?
Oh,
we can't hear you very clearly. Okay. Thank you very much.
Now, allow me to apologize for being late. I'm not sure if everyone is aware that we are going through a difficult time with the passing of one of our colleagues on the 4th floor. But nevertheless, it's nice to see all the familiar faces here today. And I really welcome the annual report in front of us. On the forward of the MEC Minister. I just want to know from the Minister, with the benefit of hindsight, what are some of the decisions she would implement differently if she were to be given another chance? And then also that's also on page 15. I just want to check in terms of, she mentioned there about the physical distancing. We know that people are not adhering to that. Is there anything that her department is doing to enforce these measures? And then also, what is the risk of transmission in densely populated settlements? And what engagements has she had with human settlement departments to implement the densification of informal settlement projects? And then lastly, Chair, of let's say the last paragraph on page 15, what has she and her department done to appreciate the dedication and selfless sacrifice of our nurses? The HOD mentioned earlier that staff want staff that is like and proud to be associated with the department. So what have the department do to those selfless those nurses, and what are the salary range of both the highest and lowest paid nurses in the province, and also does the MEC believe it is high time to re-evaluate the nursing post and improve the grading and salary levels? And then lastly, Chairperson, majority of our nurses die crying because the department failed to protect them, especially in the start of the pandemic. Because we received a lot of complaints, including that they were forced to report for duty while they were exposed to COVID-19, and hospitals were clean only, the hospital were clean late after someone was tested positive. Does the MSC believe that we, let's say the department, owes those families an apology? And what will it take for the department to build a wall of remembrance in honor of all frontline workers that died fighting COVID-19? Thank you, Chairperson.
Thank you very much, Member Windvogel, and we note and accept your apology for being a few minutes late. And please do extend our sincere condolences and sympathies to the family of your late colleague on behalf of this committee. And I wish you all the best during this very difficult time. Thank you. Member Allen.
Thank you, voorzitter. En ek stem saam in 'n gemeegevoel lid. I just want to double check. Did we table the pages already, or are we just making?
We are just now
the remarks that were made.
Yes.
Thank you.
The input of the minister as well as the HOD.
Thank you so much. On that note, I think it would be out of order of me not to commend the minister as well as the HOD. They have remained, Chairperson, unfazed in the light of difficulty. The HOD mentioned that in the face of adversity, our humanity come forth. So I do want to echo that it was an extremely difficult year for many. And if I consider reading the opening remarks from the minister in the forward as well, it's not merely words on a paper. It is where you've seen what has been happening. So I do want to commend the minister, the HOD, each and every staff member, senior management, right down to the lowest level where we know that a lot has been done. I want to commend HOD. I've seen you so much on TV. I've heard you on radio. Communication was so key in terms of making sure that residents in the Western Cape feel safer, that residents feel that they know what is happening and that they are equipped in order to deal with the grief, with the often misunderstanding in terms of what is happening, and you've been able to share that adequately and bring about a peace. I think if I listen to your opening remarks and the ministers, I find today to be here, I want to say I'm extremely humbled to be here and to have read the report and understanding that what has gone into what the department has done, and your audit outcome is highly commendable. So I just want to say thank you for all that you have done, and the chairperson will probably direct once we go into all the pages. Thank you.
Thank you very much, Member Allen. Member Botha.
Thank you very much, Chair. I don't know which mic to use, and yeah, it's difficult. I also just want to say and acknowledge the 34,000 frontliners. They are not here, but you are representing them. And as somebody who has also become a statistic of this dreaded disease, I want to say to the health sector, thank you, thank you, thank you. And also not just for myself, but to comfort others that has also gone through this, and that I had to guide during the time and had to support during the time. I once again say thank you, and I say thank you with capital letters. And I am so glad that both the HOD and the minister today rendered a heart-rendering message, and not a clinical message. Not what the wording is in the book, but speaking from the heart and really being the leadership that our health workers needed at the time, and that our province needed, but also our health workers' families needed. And I trust that that is still ongoing. The support for them is still out there, and it is still ongoing. And through what the health sector in our province has gone through for still coming out and obtaining this clean audit. So well done to you. And also well done, as I say, to all our health workers out there. And that you, both you and the minister, SG, that you have your heart in this, and that it is not just rendering a clinical service, because during this pandemic, we did not need just the clinical service. We needed the hearts, and the hearts were there. And thank you very much for being accessible, because when I called you, you would answer. No matter what the difficulty was, or no matter what happened the day before, you would answer your phone. So thank you very much. Thank you, Chair.
Thank you so much, Member Botha. And certainly, I think all of us can relate to the previous speakers in terms that we really felt that this morning. We felt it's not just a cold and clinical reflection as Member Botha alluded to, what's on paper. It really struck as to what the department had to deal with this past year, and it really came through so passionately that we could really feel it. And also from my side, a huge thank you. You are still there, you are still battling and navigating, but we are really blessed in so many ways in the Western Cape. So thank you from our side. Minister, I would give over to you now, and then you can indicate which of the questions the HOD or the team will address. Thank you.
Thank you, members, for your words of support. It does make quite a difference for the healthcare workers, not only those that are sitting this side, but also everywhere else. I think they are listening. Thank you for that. Chair, I think the questions are general. If HOD has got some other inputs, can just add, but it's just a general questions. Regarding to about what I would have done differently. We had a dream, we had wishes, we had plans, because remember 2019 was the year of the elections. So politically, we had our manifesto in regard to plans, what we wanted to do across the government, but also when I ended up being the MEC for Health, already I had my own, which is I wanted to dovetail around that. So the most important thing was about universal health coverage, which is talking about the affordability and accessibility, rendering equitable quality care services up to Tanisara everywhere. And also to see to it that the packages that are even defined in the ideal clinic, they are being rendered. But not only that, because we promised in the National Health Council, when we said we can do this NHI differently, give us a space and give us some resources, we can pilot it for you in the Western Cape because the data is already there. So that's when they said at the time, before the new minister came in 2019, they said, okay, do it. So already Saldanha Bay and also with the Eastern Cape and also with the KZN, because they said you need to other provinces to join you so that you can have lessons learned. So the King Dalindyebo in the Eastern Cape, they're already part of it and also parts of the PCM. We already had meetings with at a higher level, us as the MECs, because the last one I hosted, I think it was MEC August, the last one was hosted at 20th floor. Already, Dr. Dlomo was saying that I don't want to be left behind, I want to join in here. So we already have the plans in regard to the UHC, where we ask the private to join us, the locals, the employer to join us in regard to the social insurance or whatever. So we already have plans. That's one that I was so excited about, where I asked the team just to sit with it, how we can resuscitate that. Even if probably there might not be some interest now at the national level, but we have to do it because UHC is the way to go for this South African health system that is a two-tier, because it does have an impact on us as the public. Whether you like it or not, we might have 30% of the people who are insured and 60 or 70 who are uninsured. But at the end, especially with the economy where it's going there, we end up absorbing them. Like, for example, myself, I'm in PAMED, but I was just throwing tantrums where I have to keep on putting more money for the screening. You go for the ear irrigation, you go for the pap smear, you go for whatever, you have to add more money, yet the money that I'm paying to it, it does have a huge impact even with other medical. Because that's when I said, I might rather go to the public where I know that ear irrigation can be done by a nursing assistant, for example, where it becomes cheaper. That now I have to pay triples if I'm going to a specialist for something that I already know that I need to have. So UHC was one of it. The second part was a community-oriented primary care, because we kept on saying that health services is our core business, but health is everyone's business. And therefore, we need the communities, the civil society, and everyone to be on board. And you have to localize the principles of subsidiarity, where in Bito or in the Garden Route district, the health management, the district management, together with their partners there, they need to come up with something, which already all the districts have already actually implemented part of it. And we even went to each and every councils, municipality councils, to present us our presentation on COPC with the district health management team. And also they gave us all the space. And they said, we need you on this. So it was already there, but it also needs the WOZA and the war departments, wall of governments, WOGA for the local government to participate, and also for the national. WOZA for all the society approach, plus also WODA for all the departments. So it needs the involvement of the social development, especially like in the first 1,000 days and so forth. So we are looking forward to that. Administratively, we already passed we done our MEAP, Management Efficiency Alignment Project, where we worked our department in regard not only to the organogram, but also in terms of the packages. Just making an example. Previously, in the districts, around the districts, you'll find that you have, let's make an example of the Cape Winelands. Cape Winelands District, where you'll find that we have got two level 2 regional hospitals. And then we have got level 1 district hospitals in each using municipality boundaries. We call them sub-district, where you say Witzenberg, we have got Sirius Hospital, Stellenbosch Hospital, all of those. So at the district level, we find that it used to be the district management who will also be working with the district hospitals up to the level of the clinic and the family and all of those. And then these two hospitals used to be managed at a higher level by Dr. Karim, who was the chief director then for the specialized hospital and also for all of these provincial hospitals, which now is Ms. Juanita Arens. But the point that I'm trying to make is about when there are issues in PAL. There was a time where there was an issue, I think alleged rape somewhere in Chicago, and then you're dealing with a PAL, and then the district say that no. It's a level 2 hospital. It's a PAL hospital matter. But I said the reason that this child was delayed to be seen is because I was waiting for a family physician who reports to the district, but not to the hospital. But the family physician said that, no, I was doing my rounds in other hospital. So PAL is supposed to resolve it. But I'm saying, but you do know PAL, at the EC, they only have got the emergency doctor, not the family physician, unless that person be called. But what I'm trying to highlight is that now, with the MIP, you'll find that those hospitals, they report to that district. And then now they also have got the clinical manager, medical manager, and all of those who can be able to oversee the whole of this. Just make an example. So for the MIP, although it's still happening, when you keep on sending some of the appointments, because it's part of that. That's why when people say that, when they're going to change your structure, I said that we change it. It took us 3 years to do the consultation, also with the organized labor and everyone. That's what makes it us actually, even during the COVID, it made it easier for us to have that close communication and the relations with the organized labor, because we journey with them throughout. So there were no shocks. The other part of it is the Western Cape College of Nursing, which is now, it's under the higher education. It's also a step, baby steps throughout. The other questions, NPIs, as I always say, NPIs, which is the non-pharmaceutical interventions, are the first line of defense. First line of defense before you even go to a facility for the COVID. So that washing of the hands, the social distancing and all of those, it is not a health matter. It is there outside, because what we are reporting is what is happening already in the health facilities. But what is happening outside the health facilities, for us, we can provide the messaging, we can use like community health workers or other staff that are working in that space. But it needs other sectors. So going to the ShopRite shopping, and then if there's no spray of hands, don't call Mbombo, yeah, there is no sprays, there are no sanitizers. Call the relevant sector, or if it's a part of the Disaster Management Act, in regard to if, for example, not wearing the mask is part of where it needs to be policed by the police, call the police. Because it's not only our matter, because you ended up going to the spaces where other sectors have to take responsibility. It's similar. Look at the schools. What is happening with the schools in the Witzenberg, in the boarding school? I said, education sector must take responsibility. We provide guidelines around that space. Informal settlements, they won't be able to social distance. And like, for example, with the taxi, it was against us for the full taxi for the people to be there during that time. But the others, those sectors decided that whatever, we want to be next to each other, although we're against it. And then they came with, they're going to open windows, blah, blah, blah. But we're against that as a health. So this COVID pandemic is not a health issue, it's a societal issue. Health in our own spaces, because people say that, is health ready? I said, our health facilities are ready. We don't know whether you guys are ready. Because for us, if our beds, there's an occupation of about 20 or 30%, we will recommend that there must be a curfew because as part of it, or there must be alcohol because, restrictions because of the trauma cases that we see. So whether you apply them or not, it's your problem, but based on the data, that's what we all suggest. So in regard that whether we have the engagement of human settlements, we engage everyone. Fortunately, for the Western Cape government, we also had extended cabinet COVID meetings where all the district, all the mayors, they participated in that. Plus also they had their own district job, where our district management team with all other sectors, including the municipalities that are serving those districts, they form part of it. And then even have hotspot strategy. That wasn't only including COVID, but the humanitarian aspect, the dignity project, giving cost package to some of those where they are in need, and also if there is a high level of any other intervention that the municipality needs to do, we just make that provision. Just making an example, in Dunoon, where we even went to the ShopRite with the Department of the Economy, where there was a whole issue of in terms of the social distancing, also with the private and all of those. Health works with everyone. So that's why even in this like safety, where Dr. Kluti is also the co-chair of the safety space together with the HOD for the safety. And then the higher level, Mr. Fritz and I, and sometimes we include education in regard to safety at schools, social development and so forth, because at the end, you might not be responsible, you might not be accountable, but you absorb every social ill. So that's why we are everywhere. About the nurses, fortunately I'm a nurse, so I've got the authority to talk about it around this. Once the provinces appoint the HR and were responsible for it as part of the PSA, Public Service Act, as part of the PSA, and also in regard to the National Health Act in terms of the human resources that is aligned to the province. But remember, some of these issues about the salary levels and all of those, it's a national issue. Fortunately, I was a union also in my time. I fought my own battles where we used to say that it cannot be take 4 years to train a nurse. I'm part of that product. We used to call it the fruit salad product. When they introduced all these 4 disciplines into one, so I was one of those people who were part of the pilot, where we said you cannot be training for 4 years and doing all these 4,800 hours and all of those. You used to do night duty and all of those. And then when you qualify, you ended up earning peanuts. That is even lower than the 3-year or 4-year degree of a pharmacist, for example, and even lower. So it was the teaching and the nurses, which is still the same as that. So when we did the whole of the signing with the part of the bargaining council, so it's the unions who are supposed to raise their voices in the bargaining council. Those were still even like with the OSD, which is now, it hasn't been revised, because they cannot be able to take all these specialties and then put them more money around that. It is them who signed, who agreed in the bargaining. So they sold us short about it. So if they have to take it back to the bargaining council about these, all of issues, specialty and all of those. It has to go there. For us, there's nothing we can do as a province anywhere. But in terms of what we have done, understanding that this COVID, as we have seen, mental health state for the whole society, but also affects our staff. You'll see in terms of a part of this book where we have done the wellness programs, not only to be something there at the occupational health space, but also going to the facility so that at the time that you are busy with the patients, then you feel that I can't take it anymore. I need probably to see a shrink or something. So there have been people at the branch level working also with the unions as well, even up to at the higher level, up to all of those. We have provided all of those. The webinars related to the mental health and all of those, because having 12,589, which is the current stats of the people who have, I'm talking about the whole of the healthcare workers, not only for the nurses, who have had infections cumulatively, although it might be 98.5% of the people infected, but that 1.5% of the people who died, I think 190 at the time, it does have a huge impact. So COVID will always, even post-COVID, it will always remain with us generally, especially the mental state, post-COVID mental state, the inequality, the poverty, it's also going to be with us because some of us lost our colleagues in that space. I think I've covered. And add something.
Thank you very much, Minister
I'll add something very small. Thank you very much, Chairperson. So to Member Windvogel's question about the protection of staff and acknowledgement of the department that we didn't protect the staff and that we are culpable for them dying, and offering an apology to the to the families. And what are we doing in terms of a wall of remembrance and all of those? So just to say, Member Windvogel, as a department, we took this extremely seriously. So myself, Mr. K, Dr. Karim, all the senior management, met with organized labor from the first week of COVID. We said, let's take it out of the chamber. We're not here to contest and to fight. Let's have an open conversation. What are people anxious about? How do we overcome the anxiety? So the anxiety of PPE at the beginning, because we didn't know enough. And it was very difficult conversation, because how do you prove somebody died because they got the infection in the hospital? Everybody was traveling to work in taxis. You could have picked up the infection, looking after, wearing all the PPE or not in a hospital, but you go home in the evening, you go to a shop, you could have been infected in the grocery shop. So there was this honest conversation we had with our colleagues in organized labor. I doubt that you will find one of the senior members of organized labor that says that this department didn't do what it needed to do to be honest about how to protect staff. And we knew we went into that to say, with all the things we're going to put in place, we have to address the anxiety, talk it through with people, do the PPE. We proudly say that we got the PPE. From wave 1, that anxiety of the PPE disappeared. Wave 2, people realized actually you can be infected anyway. Whether you have your PPE in work, and many nurses started sharing the issues. That actually, I'm protected at work. When I get home and I go to shop and I'm coming into contact with a family gathering of others, that's why I'm exposed in terms of it. So it didn't become a blame placing from our perspective. And we walked the journey with organized labor. I remember being interviewed by somebody on behalf of the first nurse that died in Tygerberg Hospital. The interviewer's specific thing was to say that the family feels let down. That's in KZN. That somehow somebody failed this person. We were honest in our response to what had happened to that person is a shock to all of us. It is pain to all of us, but we've walked a journey. So I can honestly sit here with you and say, we did what we needed to do to protect all of ourselves, all our staff, and we've stabilized PPE, the understanding everybody has in all of those things for that. That's why our acknowledgement is that as a collective, we walked the journey. We had to navigate anxiety, being clear as the science evolved, but we did what we needed to do to protect the staff. We moved from the physical protection to an occupational health and safety policy. Now, we have an occupational health and safety policy that we've never had before. And we've got commitment. The lady sitting at the back, Dr. Angeleti du Toit, we have organized labor on a technical committee. The reps looking at what the ventilation should be and what is the policy and who should do what and all of those. We've never had those relationships before. So we have an occupational health and safety policy that we're extremely proud of. That's a product out of this. So from recognition, one of the big things that we have discussed is we recognize the individual people that have passed away. We recognize the impact it had on their families. And we recognize the broader impact it had on society. I think the Wall of Remembrance was something that is a very important a gesture. And Member Windvogel, that is something that we very seriously will consider. Because I believe it will give us the dignity and the closure to be able to say thank you to the people that died while serving their communities. And that we need to always recognize. Thank you. So, besides the recognition, we have taken one collective decision. I use the delegated authority, and it's not irregular. So it is followed all the rules, and there will not be an audit finding. But we have made a decision in our department to give every staff member 2 days leave. That we, in a sense, it's contribution. Very small token, but it's 2 days that every staff member could take. And the staff really appreciated the fact that we gave them 2 days leave for everything that has gone into this. Thank you.
It's wonderful. Thank you very much, HOD. Members, I will now formally table the Western Cape Health Department's annual report, Part A, contained in pages 9 to 25. And I please ask members to practice discipline in that manner, to please keep to Part A. Please keep your questions to the section that is relevant, and kindly indicate to what page your question is deriving from. Member Botha, I see your hand.
Okay, I just want clarity from you. Now, it doesn't have a page number, but it's after page 25,
Just
the
before Part B.
organizational organogram. Does that become part of the questions for now?
We can certainly do so,
thank
Member
you.
Botha. Thank you.
Can I then go?
I recognize Member Botha, Member Baku Force, Member Allen, and Member Barnes in that order. Thank you, members.
Thank you very much. On page 15, I just like to ask the Minister, because it's in her foreword, the behavioural change campaign. If the Minister could speak to whether this campaign was successful by your own evaluation, and if there are, what was the lessons learned from it? And then on page 19, I just want to give an accolade to the department for no unauthorized, fruitless and wasteful expenditure. So that's just a comment. And then on that page that I just mentioned to you, it hasn't got the page number, organizational organogram. The number of vacancies reflected the HOD. If you could speak to the impact that this has had during this period under review in the different directorates as stated in that organogram. Thank you, Chair.
Thank you, Member Botha. Member Baku Force.
Thank you very much, Chairperson. Chairperson, I have 4 questions in front of me from page 16, paragraph underneath of bullets. I would like to know what is the likelihood of getting a 4th wave before the end of the year, and what measures are in place to respond to this. And the best weapon at our disposal is to get our people get vaccinated. Can the HOD shed more light in terms of progress made in the vaccination drive? Do we have enough doses? Are there any doses to have expired or set to expire? What are the plans to get more people vaccinated? Still in page 16 in the organizational environment, I have a question at the department saying the department said 33,615 employees, 65% were health professionals and 35% were administrative. Given the extensive cuts in the budget for compensation of employees across all WCG departments, how have these cuts affected the number of employees? How has this number varied in each year between 2014 and 2021? And on the support staff, and 89% were employed in a permanent capacity. I would like to know, of the 11% that is not employed permanently, how many seasonal workers and how much does the department spend on one permanent staff and on seasonal workers? We are still on the page 16 in the organizational environment. Can we get a breakdown of the positions occupied by the 13% white employees, what is the number of African in the senior to top management? We are still on page 16, the built environment and health technology. I would like to know what the percentage of the infrastructure response to COVID-19 expenditure was spent on providing long-term solutions to our healthcare service, and why do we still have people sleeping on the floor in our hospitals, like in Khayelitsha District Hospital, and how has this expenditure improved rural health? How did COVID-19 impact on the maintenance of facilities, particularly the old facilities like Tygerberg and Groote Schuur hospitals? I thank you, Chair.
Thank you very much, Member Baku-Bakuvos. Members, we have indicated in the beginning of the meeting in terms of our time allocation for the entire session. Can I please ask members to please keep to the question? We do have opportunity in terms of our parliamentary privileges to state our statements and as well questions pertaining to what we reflect on today. But we kindly keep to the annual report deliberations for 2020-21, please. I recognize Member Allen and then Member Barnes. Thank you.
Thank you so much, Chairperson. I'm going to keep it brief. I know the Minister answered earlier on already regarding the learnings that were implemented. I was interested in learning how the principles not to, in terms of new viruses and how those learnings will be implemented. But then on page 16, I know there's a number HOD for 9.6 million primary care contacts during the financial year. Are you able to give what's the actual amount in terms of people, residents that used primary care, that were primary care contacts? In terms of the amount, I would assume those 9.6 million would be a person that had double contact. So what is the average or the amount? And then there is an amount for 558732 patients that were transported. I know, and this comes up often, but do we have an average waiting time for the period under review? And then still on, and this is my last one for this part, on page 16 as well, under organizational environment, there's a figure of administrative staff and 89% were employed in a permanent capacity. Just out of interest, like, how do we rank in terms of other departments across health departments across the country in terms of the permanent capacity, if you would have an idea in that regard? But then closely, in terms of the role that this department played, are you able to share briefly in terms of how assistance were possibly provided to other departments across other provinces? Thank you.
Thank you very much, Member Allen, Member Barnes, and then after Member Teugo online. Thank you.
Thank you, Chairperson. My first question will be on page 18 under program expenditure. There's an under expenditure recorded of 250 million. What I want to know, Chair, is what would be the justification of failing to spend over 250 million during such a difficult experienced year, and whether has this been recorded as a rollover? My second question on page 19 under the top table, second row, to address over expenditure as a result of thefts and losses. What was stolen and in which hospital? On the same page 19, Chair, under future plans, the department table its 2019 up to 2024 strategic plan. There's a link attached that when you how to read the plan. I assume it's a big plan, but I do have a request, as HOD earlier said, that the department is here to account. Can we be taken into confidence just to get a brief gist as to what is the strategic plan actually about? Just enlightenment on that. On page 19 again, Chair, public-private partnerships, the last paragraph, following receipt comments from National Treasury, WCGH submitted a comprehensive response at the end of 2020-2021 financial year. Can the department prepare a full report for the committee on this PPP, including the comments received from National Treasury and the Western Cape GH response to it? When will the building project commence? Chair, I think that is my only questions for now. Thank you very much.
Thank you very much, Member Barnes. Do you also have a question, Member Van Vogel? I will then first just go to Member Kergo and then come back to you. Member Kergo?
Thanks very much, Chair. Mine is on page 19. I'm partly covered by Member Barnes, but I just wanted to understand the issue under the Tygerberg Hospital project. That how far is it and what could be the possible hiccups to this anticipated project? And in terms of redevelopment of that hospital. And then on, I think it's page 26 because it's not numbered, because it's, the last page numbered is 25. Under the organizational organogram, there are a number of vacant positions that are there. And then what we need to understand is that how long have they been vacant, and if there is any plan in place to fill those vacancies, and if they do not hinder on service delivery. Thank you very much, Chair.
Thank you very much, Member. Member Van Vogel.
Thank you, Chair. Chair, mine is also on page 20. The new proposed activities. I want to know, where is this facilities built? Perhaps I missed it somewhere in the annual report. And then what are the plans to build more of these facilities in remote areas like the Karoo, where patients spend days? Previously, Member Barnes mentioned it on floors while waiting for ambulances. And then, Chair, the last one, what is the risk, also on page 20, what is the risk of corpse contracting the virus from mortuaries, and what measures are put in place to mitigate the risk? Thank you, Chairperson. The corpse, that is on page 20, the FPS.
You concluding with that, Member?
Yes, yeah. How is the facility going to help address the shortage of forensic personnel in the province? Yeah, I'm concluding with that. Thanks, Chair.
Thank you very much, Member Van Vogel. I just want to ask the question on page 18, the second table, linked to the question of under expenditure. I see that in program 1, the bulk of 99 million is linked to administration. Just what the causes thereof was. Is it in terms of human resources, vacancies, or we've also seen during the time elective health services, was that perhaps something to do with that as well? Thank you very much. That concludes this round, members. Thank you. Minister.
I think thanks for the questions. I think the ones that are generally, I'll answer the one from the behavioral change in regard to the forward. Again, just to recall that this was the same time, it's in between. It's a time that the pandemic is just started during this reporting period, which is in March, which it starts with the general public behavioral change, plus also for the staff. Because all those fears, it was about a disease that was unknown. And then it includes the screening, community screening and testing. And then it ends up with when now people were supposed to be ready for the vaccines, but for the staff. So it means that you have to combine as many of the approaches and also to target the misinformed, the uninformed, and the whole of the packages. So just to highlight some of them, especially the work that was done by the community health workers for community screening and testing. I recall at the time it was also linking with encouraging people to use the Q&Is. I remember the one that we did it at the time that Ms. Ahrens was the director for the Tygerberg Northern. We went with the healthcare workers going door to door, but also with a taxi as part of the red dot, so that people, they know they can be transported safely. Where we say using that kind of a language. So it's one of those behavioral change. And the other ones, it's about related to the distancing, which is the physical distancing in regard to stay in your bubble. Because always when there's a new information in the COVID space, because you also have to link with what is happening across. So you'll find that the other information might not necessarily be relevant. Just making an example, where the time earlier it was not seen as being airborne, although it was aerosolized. So the issue of the cleaning all the surfaces and all of those, it ended up changing where it says that don't share your airspace. It is in the air, but yet when we started, it wasn't much about it. And then up to where we talk about the 3 C's in terms of the crowd, the contact setting, and all of those. So we have to keep on providing as new information emerges. You have to change your behavioral change. And also luckily with the universities and the team, and then we'll zoom in some piloting. I think there was a study that was also done in terms of the wearing of the mask. When do people wear the mask and when they don't wear the mask? Where we said now we want just to be becoming something that is fashionable. Like there was a time where when you're going to speak, you take off the mask. And then we'll say that actually you can't. Because not necessarily that you might be infecting the people, but you'll end up forgetting now in another setting where you cannot take. So we came up with various approaches in regard to the behavioral change, but also tailoring it to the localized context, because the approach, for example, we will apply in the Central Karoo, in the Lehamka, Member Bands area, and all of those. It's going to be completely different with the one that you apply, let's say, in Khayelitsha. So we have to tailor-make according, and also you have to understand the context, the settings. Just making an example, in the lockdown level 5, people say that stay at home. We are so scared even to go outside. But the question is that in the informal settlement, you're actually far much better, safer to be outside than to be all squashed in under one shack room, one room, and all of those. So therefore, the team in those areas, they will have a tailor-made kind of a message that is different. That probably will be focusing on when people go for the queuing for the SASSA, or also when they're going for the shopping, than about where isolate in the back room. There's no back room. So this is the kind of things that we dealt with. I think the other questions, again, Chair, just a reminder that we, some of these, I mean, the year under scrutiny, it ends 31st March 2021. But if we have to respond in terms of as educationally, I don't think we have got an issue with that, but we don't have to respond to any of those. Just making an example about the preparation of the 4th wave, that information is crucial because we are here, we want to know, are we ready for the 4th wave? So we cannot dismiss that part of it because it's a general question. But about some of the issues in terms of the others that are not necessarily part of this. So it's up to the department if they want to respond. Over to you, Dr.
Thank you, Minister. HOD.
Thank you very much, Chairperson, and thank you, Minister. So if I can just very quickly then run through them. There's a question about from Member Botha, and it was also by Member Kleko and by Member Kleko. So I'll answer those two together, and it's got to do with the organogram. So just to indicate to you that this is an organogram for the 31st of March 2021. Minister Mbombo gave you an introduction that on the 1st of April, this organogram changed. So the first part to the vacancies is some of them are deliberate vacancies because we've realigned and we've restructured the way we operate. So on the 1st of April 2021, the organogram was replaced by something else. And it's a much more streamlined organogram, which means Mr. K is the head of corporate services. If you look at this organogram here, it still says that the head of people management reports directly to the HOD, the head of infrastructure reports directly to the HOD. Mr. K is the CFO, and he has the head of supply chain reporting to him and finance. From the 1st of April, he's the head of corporate services. So people management, infrastructure, supply chain and finance all reports to him. Ms. Nkosi has been appointed as the head of finance. So she is now, his team is complete. He's got a head of each of those units. So if you look at Dr. Karim, and if you look at this organogram, it says there are 2 DDG posts. Now, I've worked for 5 years, and there wasn't 2 DDGs. I was been the head of services for the last 5 years. The organogram that you see here is an organogram that's actually not had 2 DDGs for the last 5 years. But on the 1st of April, that other DDG post falls away. So therefore, it's not a split of the some services on the one side, some on the other side. And you can't match it quite. So Dr. Karim has the chief director, the heads of Tiger Begrootski and Red Cross reporting team, 1 chief director for Metro Health Services, 1 chief director for Rural Health Services, and Ms. Arendse has been appointed as the chief director for emergency clinical services support, which doesn't exist on this organogram. So you have to understand that from the 1st of April, we have changed the organogram to be leaner, much more streamlined. And actually, the team of people here is doing, well, maybe I should be very careful of my words. This is a leaner structure than in many other places, but a much more effective and efficient healthcare system that we run. So I think it answers the questions of the organogram. If we go to Member Baku Force, I take guidance from the Minister. And then to say, Member Baku Force, I will answer that I think we have an ad hoc committee meeting coming up. And obviously we will give the detail in the ad hoc committee on where we are with the 4th wave, what's the status of the vaccination, do we have enough doses, what measures are we putting in place, all of those. Just to assure the member that we've learned from the 1st wave and the 2nd wave, which is part of this reporting period. You will recognize that the 3rd wave is actually was after April, after March. We've learned from the 1st, 2nd, and 3rd wave. We are currently working with our scientists and with all the, let's call it policy formulation structures in the country, and we're formulating a 4th wave preparedness plan. So we're submitting our plan to the National Department on Friday, and by next week we will have a policy discussion. I'm joining a NHC Tech meeting tomorrow. The Minister will be at the NHC meeting next week, Minister, where the plans for the 4th wave will be shared. But remember, we are not working in isolation. We are one province, and our 4th wave preparation and our 4th wave plans is very much part of the country's 4th wave plan and how we deal. The same with vaccination, the same with all the other things. So there's a lot of detail, but that's the overview in terms of where we are. If we go to the question about the 89% people permanent, I just want to clarify. I think we clarified it last year. Just want to clarify again. A health department, by nature of the posts it has contract posts, because a big proportion of what the health department does is to train people. So the majority, when people read 11% or 13% not permanent, people think we're talking about agency staff. We're not talking agency staff. We're talking about people that are appointed on contract. That means if I'm an intern, medical intern, I get appointed every year, or the interns that's finished, they get appointed into a contract position, not into permanent positions, because at the end of year 1, their 1st year intern is, so then they exit the contract. End of year 2, they exit the contract. If you're community service, you also get appointed into a contract post. because community service is a 1 year. So you get appointed, and at the end of the year, you must vacate the post because it is a training post. If you are a registrar in any speciality, and we've got lots of registrars, you get appointed for 4 years in a contract to study your speciality. At the end of 4 years, you must vacate the post. So there's probably an understanding that we need to clarify so if we benchmark that against other provinces, Member Allen, we can proudly say that in terms of permanency of posts and movement of posts, we have greater permanency in this province than many other provinces. So I just going to give you that as a broad overview of clarifying that. But if you go into the more detail of that, and it's really about what has happened to the 89%, has this shifted up and down over the years? It's more or less stayed stable over this entire period. So you're asking, remember, Buckerforce from 2014 all the way to now, it stayed stable. And what we've been able to do, we have been able to add more contract posts, right? Because of COVID and of vaccination. So on top of all of those interns and all of this, we've actually increased the number of people, right? So it's not as if we've taken away from all of this. We've added the number of staff on top, and we have big numbers, 700, 1,400. In the third wave, we were up to about almost 2,000 additional people. So that's what we've been able to do on top of that. And again, it was a contract position because if you say we are going to deal with COVID, we're saying for a period, there's going to be many people that has to be admitted, but at some point, especially if we're going to vaccinate them, they're going to be discharged. So we have to then say that the money we're getting is then to fund for people for the additional hands we require, not to do it via agency, but to actually get contract positions. And then at the end of the contract, obviously we look at where can we absorb people, like the question that was previously asked us. We have community service nurses. Community service nurses is in a contract position. At the end of that community service, they need to, but all the nurses then applies for vacancies in our situation. So I just want to understand that people understand as a healthcare system, that is what we mean by permanent versus contract. If we then go into the 13% breakdown of white people, right, to see where are the 13% of white people. Obviously, we have in a sense, one of them is Mr. K, but we have a sense of where the white people are in the organization. I think the question was, how many African black people do we have in senior management? Now, we've previously had that tabled in this department. This administration with the minister take diversity seriously, and in appointing people into senior management position, we take our employment equity imperatives seriously. So we can give you an indication that our percentage of people in African black in senior management has increased over this period. Again, it's out of the reporting period because we have to then table that formally with you at the right time. If you then go to the infrastructure question, so I think your infrastructure question is the point that we make in that paragraph is that because of COVID, whatever we planned, you heard the minister's plans for UHC, COVID interrupted that. Whatever we planned for infrastructure was interrupted by COVID. So the point that we make in that statement is we had to do those tents and we did them quickly. The tents came and went, so the tent was to test people when they came into facilities. And it was at every big place where we say, you're going to come in, you test, you triage it, you don't stream the person in there. But we also did other things, which is, for instance, we did the CTICC. We brought that on as a 850-bed hospital, brought it on, but then we also decommissioned it. We brought Brackengate on and we kept Brackengate. We converted Mrs. Plain Hospital of Hope into intermediate care facilities so that if the fourth wave comes and we need it, we bring it back up. So we learned from this thing about having hired outside places versus investing in infrastructure that we can actually call upon when we actually use it for going forward. So your question about why are people still sleeping on the floors, what has been happening in infrastructure in rural, and all of those things, the bigger thing is that there is a broader infrastructure strategy our ability to meet all our infrastructure needs in a 12-month period while we have to cope with COVID, some things had to give. So some of our plans are delayed, and you'll see we'll come later into the document that the forensic pathology unit was one of the areas that we had to delay it into this financial year. But there's a lot of other plans, and we've also learned with our infrastructure colleagues to actually rethink infrastructure. Because we've done things quite, if you go to Sonsstraal, that's an existing TB hospital. We put infrastructure there in quickly, and Sonsstraal now has got much more beds than it was, and it was quick. So we also learned how to do things differently and work with our infrastructure colleagues in that way. That doesn't take away from the fact that, and then we said this last year, that service pressures at any given time. Our healthcare system is premised on the fact that doesn't matter what infrastructure you have, in an EC, in admission ward, all of those. At any given weekend, with lots of alcohol, with lots of trauma, with a whole lot of things working together, any health facility in our province can be overwhelmed at any given time, irrespective of what healthcare infrastructure is in that area. That has got to do with us being able, and that's what that point is actually about in the EMS, when I come to that later, is being able to move patients where the pressure is away from a place to pressure and move them somewhere else. So inter-facility transfer becomes important because we want to give dignity to every patient. So if we get overwhelmed in one place in Khayelitsha, we got in there and we moved people to Brackengate so that people don't have to lie on the floor. That is the thing that we combine in terms of all of these. Member Allen, I think it's quite important learnings we take seriously, and we have a passion for learning, and you can see across all of this. It's learning about how to do medicine differently, learning how to phone diabetic patients with COVID and care for them differently, and fewer diabetics dying. There's so much learning. So we're building all our learnings into the way we do business differently going forward. We're very excited about that. We want to reform the way we make decisions, the way we govern, the way we deliver services, the way we work with others, and the way we're going to implement the minister's dream of UHC. We want to do all of those differently with the learnings that we've done. The question that you have about the 9.6 million PHC headcounts, that's a very astute question. Thank you for asking the question. Our colleagues have been working on that for a very long time. So just to answer you, a very short answer on that, because we can get carried away in the Western Cape when we talk about this. The reason why we have a dashboard and we can tell you who is infected where is because we have a provincial data health center. And the provincial data health center doesn't just work on aggregate data. You know, aggregate data is you count up how many people came in, but you have no idea whether that person is the third time they come, the fourth time, or it's the first time. Now, the whole national data system is all on aggregated data. Because we have a provincial data center, we can actually work out that 9.6 billion counts from our data center. We can tell you exactly how many people that was. Because we can go see out of that 9.6, how many people came twice, how many people came 3 times. Actually, the last time I did an analysis, Krish, we did, I think, eSequa or somewhere. Robin did it for us. And there was one person in eSequa that came 25 times. You know, so the point is that we actually have a provincial data center because it is on a unique patient identifier. So every person has a number, every individual person can be identified. Obviously, with POPIA, we are very careful to protect the identity of people, but we can do analysis to give you exactly that figure. And that for us we believe for Minister Mbombo's UHC for the future, that's a critical thing. You need to be able to say, what does each person get wherever they are, not an average number of people. If we go to the transported and the waiting time, it is dealt with, Member Allen. I'm not going to give you all the pages, but there's quite a few places in the document where we come back to the waiting time. It's program 3 under the next section, and we will then discuss it there. Then also, I said that we compare very well with our 89 permanent posts and that we brought additional bodies in. So actually, there's a COE comparative across all the provinces, Member Allen. So when I say COE, it's how much money and what percentage of your money do you spend on staff? And the National Treasury, National Health has made an analysis across provinces. Our COE, so let me just summarize what that finding is. The finding is, in our province, for the 34,000 people that we employ, we spend per capita, per population, not the most amount of money per staff, on staff across the country. We're actually one of the most efficient health departments because our number of what we spend on permanent staff per population is lower than most provinces. But in that, we have the highest variation of types of staff. So although we spend lower than other people per population, we have more psychiatrists, more cardiologists, more highly specialized staff than you find in any other province. So there's a combination of not just staffing, but it's also the skills mix that we have in terms of that. Now that is a comparison that Mr. K and his team works very closely with all 9 provinces when the CFOs and the people get together to compare across the country. And just very shortly, in my period as the HOD, I've established very good relationships with Eastern Cape and with Limpopo. We are following through with the other provinces. I've been approached by Gauteng. I've been approached by KZN to assist them in terms of that. And we've got a long-standing relationship also with Northwest. Northern Cape has also approached us. So virtually almost every province is approached, but the working relationships are working together very strong between us. Our Eastern Cape team and us are meeting again in 2 days' time. We want to do the same with Limpopo, and then we want to follow with the other provinces. In terms of Member Barnes' questions, Member Barnes, I'm going to defer that to Mr. K. He's got a very good answer for the 250 million underspend. And you're right, it is a very deliberate intention to cover the expenditure of COVID in this financial year. So he will explain exactly how that 250 million underspend is. Chairperson, he will also explain that the 99 million that you're asking about, the detail is on page 37. And when we get to page 37, you will see the detail. And again, that 99 million is held centrally, mainly for PPE, for testing, and for all the COVID expenditure. In terms of thefts and losses, Mr. K will also explain that. And then the strategic plan on page 35, Member Barnes. Page 55 summarizes the strategic plan. And if you look at page 35, it will give you the strategic objectives in the strategic plan for which we have much greater detail. And the big thing there is we're looking at life expectancy. We're looking at maternal mortality and under 5 mortality. We're looking at TB and HIV, suppression of viral load suppression. But then very importantly, we're looking at a functioning healthcare system with unqualified audits, entropy, and then looking at all of this. So our strategic plan is a very clear strategic plan towards UHC. And that's where we are. So it's very clear. It's a public knowledge. Everybody can look at it. And we will learn, as the Minister said, to adjust our 5-year plan to get to our UHC targets in terms of that. Then in terms of Tygerberg, both Member Kleko and Member Barnes, there is detail there that is provided there. And Ms. Dr. Anjoletti Detoy, that's behind me, can give you a summary of the detail. But there's a clear process. Mr. K, maybe you can also just maybe touch on that, on the Tygerberg. And then the only other thing there, Member Windvogel asked, where are the facilities built? The EMS response, Member Windvogel, that paragraph that you're talking about, it's EMS having to take people between ICF facilities, that's intermediate care facilities. So that means, Minister Mbombo also explains this very well whenever she answers this. We see CTICC and we see, a lot of beds. Then we see Brackengate. And then we talk about Mrs. Plain Hospital of Hope. And then we talk about Soonstra. What we don't talk about is virtually in every rural district, there is 20 beds here, 30 beds there, 15 beds there, that's been made additional. And we've done infrastructure adjustments to be able to accommodate COVID patients across virtually all the district hospitals everywhere. Vredendal, Hermanus, Harry in every area, Oudtshoorn. And that is local amendments to take space that was there, upgrade it, renovated them, and importantly, make access to oxygen available across all of this. So what this refers to is the ambulances being able to move patients from one area to the other. Because where there's many patients, for instance, today in Robertson, there might be many in Ceres in 5 days' time. But when there's many patients in Robertson and they need to move, they go to Worcester. When Worcester is getting full because Ceres might have more patients, people go to Soonstra. So that's the movement that they're talking about in terms of that. And we're very proud that virtually in every rural town, we've had the ability to either accommodate the patients, and if it is too many, to move it to a nearby hospital via the EMS guys. Then in terms of the corpses, so I think Minister Mbombo answered this issue about risk. And if I and I don't want to minimize this issue, because remember Windvogel, when we started off, a colleague of mine describes it nicely. At that first couple of places where we thought COVID was spreading, people were saying if you speak or you sing or you sneeze, it was almost talking about that you put glitter into, so he was using the analogy because we believe it was droplets right at the beginning. That's where, when you speak, that the whole thing comes about surfaces having to be clean. That because it's droplets, you can get it by touch. You can do all of those. The science has moved on since then to say it's more about having smoke in the air. So he uses the example, if somebody was a smoker and you take a puff of smoke, cigarette smoke, and you blow it into the air, if you can smell it, you're exposed to COVID, as opposed to droplets that drop on the surface. Now, because that science has moved, the initial precautions around dead bodies was that the biggest risk they pose is the touch bit. But actually, a dead body, the person has stopped breathing. So they're not actually putting it into the air. So, but there was very, very clear precautions taken about the persons having to wear gloves, how they actually deal with the body, whether it's single bagging, double bagging. All of that was done by our forensic pathology services to be absolutely sure that the transmission, but between us, we think the transmission from dead bodies, the risk was much lower than somebody that's alive, that's breathing out in the space in terms of COVID. I think I've covered all the things, Mr. K.
Thank you, HOD. Mr. K.
Thank you very much, Chair. Thank you. Thanks, Keith. So let me answer the under expenditure question, or maybe we shouldn't talk about it as under expenditure, but rather savings. We didn't know what our COVID response was going to be. We didn't know how much it was going to cost, so we did some estimates, and they were our best estimates. And for that, we were voted additional funds. And as it turns out, we probably slightly overestimated in that particular period what we thought we were going to spend on COVID. And hence we had savings. And in fact, we actually even got a third adjustment budget in March, because we were coming out of the second wave. We didn't quite know what we were going to need to do to prepare for the third wave. And as it would have, we underspent, or we saved about 220 million rand of the COVID funds that were allocated to us. And thank goodness we did, because those are going to pretty neatly cover our fourth wave. And I said we're not really talking about this current financial year, but there was obviously a continuation into the current financial year. And the funding that was allocated to us in the current financial year, there was very little that came out of the national fiscus. In fact, generally the response money was significantly less. On top of that, there were some rollovers, so there were some money that was invested, particularly in Keith has spoken about the data center, the provincial data center, and our reliance on technology. And so we've got rollovers for projects that have continued into this current year. So yeah, I think the other thing which is quite critical is a culture within the organization. We don't spend for the sake of spending. We would rather show a saving than to be spending money on something that we didn't necessarily need, because the relationship is such with the provincial treasury is that we can then approach them to get that money for the following year. And as you would imagine, and as you would have seen, the finances are not looking particularly good in the country over the next period. And so we've been quite conservative in the utilization of our budget. So from the where we're sitting, it's a good thing because ostensibly we are saving for next year when we're going to have the pressures. The questions on the thefts and the losses, look, at the end of the day, we are always going to have some element of thefts and losses in an organization of our size. Those dealt with where necessary, people are dismissed or the relevant sanction is applied, and those details are found within the I think it's HR section Part D. It gives a fair bit of detail in that. But again, I mean, our level of ethical compliance and what we require out of our staff is very high. There is an expectation that we won't engage in such activities, and where they are found, they are dealt with quite significantly. In this instance, there's a matter that was referred to forensic, FB, but it was around theft of petrol, misuse of petrol cards. And fortunately, we got the systems to be able to pick these things up that there is something amiss, and then we refer those kind of things and those transactions to the right people who can then go and investigate. And where necessary, criminal cases are laid, and certainly the actions are taken. The third thing that I was asked to talk around was around the infrastructure, and particularly Tygerberg. And you'll forgive me, I'll digress a little bit or expand a little bit. So as part of our service redesign, the one area that we're looking at is the general specialist services, which is ostensibly the regional hospital services, and particularly within the metro. So you can't look at the Tygerberg PPP in isolation to 3 or 4 mega projects. Now, the issue with the Tygerberg PPP was we need to split out the 2 hospitals, the services, into the Belhar Regional Hospital, and then rebuild the teaching hospital, which is the current Tygerberg Hospital. Now, these things don't come cheap, and in fact, we had previously asked, and the province is unable to afford the kind of capital investments that are required. So funding has become the big issue, about where we're going to find the funding to be able to do these things. Now, part of the feasibility study is to actually prove, and the reason we go with the PPP is for somebody else to provide the building and the capital, for us to then be able to repay that as part of a unitary fee. Now, that can only come out of the savings that are found at the facility by splitting out the 2 different kinds of services, which are radically different. So that's the complexity. And when you're talking around a project that is probably 9 to 10 billion rand, there is obviously a lot of due diligence, and this is not something that we are able to make decisions on by ourselves. And hence, you have to have approvals from National Treasury before you embark on these particular things. We are hand in glove with the provincial treasury in this particular matter, and then we did get, subsequent to this year, we got budget facility financing for the Klipfontein and the Belhar regional hospitals out of the different pot, a different national pot of money, which again is really allowing us to look at developing 3 or 4 really massive hospitals within the metro. I think I have covered. Thank you, Chair.
Thank you very much, Mr. Kay. Members, can we conclude with Part A? You happy? Members, then we will now accordingly suspend proceedings until 11:15. We will be back sharp. There is something for you to have in the members' lounge, and please be reminded of safety protocols. Thanks, members. We will start the second part of our meeting. Minister Mbombo and Member Baku Bakufos will have coffee after 1. Thank you very much, members. Thank you very much to the Minister, the HOD, and the entire departmental team. We are now back for the second part of the meeting, and we proceed with the Western Cape Government Health Department's annual report for the period 2020-21. Members, I now direct your attention to Part B of the annual report, which deals with the performance information, pages 29 to 90. It is quite a big part, so I would ask members to kindly keep their questions to the point and as short as possible. And please then also remember to direct the Minister or the department to the page that you are referring to. Can I have an indication of members that wishes to pose questions on Part B of the annual report? I do not see Member Tergo back online, who will probably perhaps join us. I see Member Baku Bakufos, I see Member Allen, Member Windvogel, Member Barnes, in that order. So members, please note when the speaker finishes, you can directly go over and pose your question. Thank you.
Thank you very much, Chairperson. My first question is on page 31. In the ambulance, rescue and patient transport services are provided from.
My apologies, Member Baku Bakufos. I am so sorry for interrupting you.
Okay.
During the break, we just had a request from the sign language interpreters that members please speak into the mic because they are having difficulty to translate your version. Thank you very much.
Thank you, Chairperson. Am I audible?
May proceed. Thank you, Member.
Okay. My question is on page 31. I would like to know how has the number of ambulances and personnel changed over the past 3 years? Of the 1,551 personnel, how many are employed on permanent basis? Can we get a breakdown of the deployment of ambulances per district? Example, how many are deployed to Khayelitsha, Klipfontein, Mitchells Plain, and southern suburbs? And the second question is also on page 32. I'd like to know how many of these are in the rural regions. Can we get a breakdown? What is the number of forensic pathologists employed and are there, and any staff shortages? The last question is also on page 31, on the last sentence. What was the department's involvement in the calls by the provincial government to allow lift ban on sale of alcohol and cigarettes, scrap the COVID-19 red list of countries, and to reopen schools before the province reached the peak of first wave? Was the department involved in any way? Thank you very much, Chairperson.
Thank you, Member. Member Allen, is that you now?
Thank you so much, Chairperson. I am partly covered by Member Baku Bakufos regarding EMS on page 31, which links back to the opening page 16 question regarding EMS services. I do know the content under EMS, And if I can link that back to page number 49, and I see HOD the number of the output in terms of the response time, 15 minutes, 30 minutes, up until 120 minutes. If you can speak to that, but the question, and I'm not sure if this question is going to make sense, in terms of the actual amount of ambulances that we have against how many is potentially not available due to it being serviced, or it's no longer roadworthy for whatever reasons. Do we have an optimal amount of ambulances that we need where we are able to bring down the response time? If you can speak to that, like the optimal amount, and no budget is always tight. If you can speak to that one, and then just my last one, Chairperson, is in terms of page number 67. I welcome the strategies to overcome underperformance, and I'm keen to hear more about the appoint a race to zero champion and associated champions throughout the department to give momentum to and realize utilities consumption savings. If you can speak to that, I'm not sure if that is a new innovation or a new project that is being implemented, but info on that, please. Thank you.
Thank you, Member. Member Barnes.
Thank you, Chairperson. Ecosoblat said 32 Service Delivery Improvement Plan. The National Department of Health initiated Ideal Clinic IC program. What I want to know, Chair, can the department furnish us with a status report for each of our clinics with clear scoring highlight areas of concern? My second question, Chair, will be on page 33 on the actual achievements, percentage of clinics with IC status. Why is the number of clinics with IC status declining every year? And does this indicate the standard of care in clinics is decreasing? What are the details of the clinics with no IC status, and what are the identified deficiencies? What are the details of the clinics that got silver, gold, and platinum categories? My follow-up question will be on page 33, Chair. Paragraph between tables, the number of primary health. What caused the significant decrease, and how exactly did the de-escalation of service contribute to that? Now, Chair, I'm on page 34 under conclusion. The Western Cape Government Health has embraced the Ideal Clinic realization and maintenance program as a systematic approach. What I want to know is that, is this not shocking because the Western Cape Government opposes the national government? In any ways, is the Western Cape Government proposal to improving service delivery and quality of care? My last two questions, Chair, will be on page 42, the bottom table, vitamin A 12 to 59 months coverage. Why was the target not achieved, and what mitigation factors were put in place to minimize the impact of COVID-19? On page 43, the table on top, ART children remain in care rate. Is this antiretroviral therapy? If so, how many children are on ART in the province, and why was this target missed? Page 46, the bottom table, complaint resolution within 25 working days rate. Why was the target not achieved, and how long did it take to resolve? My last question now, Chair, is on page 47, the last row, Eden Municipality. What are the reasons for overspending by Eden, Cape Winelands, and the city? I thank you, Chair.
On Eden, can you kindly
repeat the one on
please
Eden?
Repeat, Member?
Okay, then on page 47, under Eden municipalities, what are the reasons for overspending by Eden, Cape Winelands, and the city? That is the question. I hope it was audible. Thank you, Chair.
Thank you, Chair. Mine is also on page, or let's say page 29, primary care. The integration between the province and the city health. What updates can be given regarding this from the let's say HOD? And what updates can the department give regarding the opening for more clinics to operate for 24 hours? How many clinics are operating currently for 24 hours, if there is? Then, Chairperson, the intermediate care. What are the plans to open more of these facilities in the rural regions? And then page 30, District Hospital. I think, I'm not sure if the HOD is aware, Chairperson, but I have seen the disturbing picture of patients sleeping on the floor in Khayelitsha District Hospital. What I want to know, what is happening at the hospital and what is the action plan to address the problem? And can we get an understanding of what steps were taken to address key challenges raised in the NCOP report following oversight visit to Khayelitsha? And then, Chairperson, page 30, what is the update on the project to rebuild the GF Joost Hospital? This is one question we ask every year. I understand it was mentioned earlier by the MEC of Minister that because of the pandemic, we couldn't, department couldn't do what they planned. But I want to know. This is, as I mentioned, that is a question I ask every year. So can we get at least an update on work conducted between the last annual report and now? And then, Chairperson, the specialized on page 30, the specialized hospitals. Are there plans to build any additional hospitals, specialized hospitals in the near future? Then my last question, Chair. Can we, on hospital care, can we get a breakdown of how many of the department staff complement are employed in each of the different hospital categories? Thank you, Chairperson. Can we get a breakdown of how many of the department staff complement are employed in each of the different hospital categories? That's under hospital care. Thank you, Chairperson.
Thank you very much, Member Van Vogel. Minister Mbombo.
Thank you. I think I'll jump around because some of them, we have got the managers who are in charge of some of these. For example, the question from Member Baku Force on the ambulance, which is also Member Allen has asked, and also in terms of the how many in rural regions like the FPS and all of those. But on the alcohol and the tobacco and all of those in terms of the ban, with the COVID, because it's managed as a disaster management act, which the custodian is the COGTA and also the president. So that's why when it's a president who has been making most of the initial announcements because it's part of the Disaster Management Act. So other sectors make a contribution in regard to that space. So in the space of health, I'm talking now about health as in the national health, the MECs and also the HODs that are participating there. For us, it's not in our mandate. It's not in our mandate in regards to say ban alcohol and all of those. But with the evidence that is sitting with us, for example, in the Western Cape, in the trauma emergency centers, where now these cases compete with the COVID. And from our evidence in there, we've got what we call HEPTIS, which is the hospital emergency trauma information system, where we've identified some of these hospitals where we zoom into collecting the evidence. So for us, it's about, because of this evidence, it means that especially during, for example, the third wave, that there will be the Christmas, there will be the New Year, and we always know that. Always we have got a high level of the cases through the substance abuse, including the alcohol. Therefore, for us, it's about give a space for the health in order to function. Therefore, that's what we suggest. So we always make suggestions throughout. And then it is them who come up, we say, lockdown 4 or 3. It's not even our mandate to talk about the lockdown. It's not our own thing. So it's them who talk about all of those kind of, in terms of what needs to be done. So they always consult health at the national and also at the provincial, But anyway, in terms of the disaster, it has always been the national mandate who has been communicating about these. In as much as that the Premier might have also some, or the Premier or other sectors might have also some of their input in regard to that space, because at the end, it's up to the national in terms of the contribution, but we provide those. At the time of this report, we also came up with warnings levels, where you have the green, the yellow, the orange, and the red, where we could be able to say, as a health sector, if it's happened that the positivity, how many cases are how many, the positivity rate is how many, the bed occupation, utilization of the bed is how many, and whether it is occupied, what is the percentage per district, or how many districts are affected. These are the kind of the recommendations. So we have got that in place in regard to that, but the implementation and also the custodian of all of this is at the national level, not to us, but everyone consults health. And I made an example earlier that in as much as that for us, we're even against the issue of the full taxi, where there was a need for, we're still speaking the language of 1.5 meters. But the transport sector and the national health agree that we're going to full up these taxis. So there are things that are beyond our control, even if we want it to be another way around. And then generally, I'm just responding generally in regard to the EMS and the response time. You may recall, we once came up with a response time improvement plan. It was mostly, specifically in the metro, it was during the time when this indicator, it was mostly impacted because of the red zones, where people have to go via, the EMS have to go via the police station in order to be accompanied to the sites where there were high level of crime. So it did have a huge impact on the response time, but up to the level that whilst we get this intelligence from the subs in regard to the red zones, but the team also might need to use their own discretion in regard to that space. So there are many other factors that does have an impact on the response time, especially in the urban area. And also you might also see that it's different times. We always know that end of the month, from Friday, 6 p.m. until early hours of the morning, 2 a.m. on Sunday. That's when the high level of the interpersonal injuries are happening and our ambulances are busy. So by default, it means that it will have a huge impact on the response, because if there are shootings somewhere in Hanover Park, and then there are stabbings somewhere in the Delft and all of those more or less at the same times, it will have a huge impact. Even in the rural areas, like in the Paarl East, in the Evian Park, in the Worcester, that will have a huge impact. Again, generally on the ideal clinic, remember, it's not all about the numbers achieving in terms of how many have been able to get the status gold and all of those, but look at the package. Recently, I was, which clinic was I? But the issue where you'll find that additional packages of care that were not necessarily part of the comprehensive list, but now people can be able to have an access to, like the eye care, where you'll find that people have to wait to be seen by the eye specialist or the whatever, waiting for the list in the district or in the level 2. But now this is being brought at the doorstep. The occupational, the physio, that become part of the package, especially in rural. I'm not talking much of the metro. I'm a plus Mesa. So in the rural, where you'll find that some of these components in that small clinic, you wouldn't have thought that they provide all these packages as part of the ideal clinic. And as yet previous, you'll find that it was only about the primary health care related to the wound, your immunizations, and then you have a doctor that comes maybe once a week. In some others, we'll find that they might come, maybe they are there every day on certain whatever. But now when you have got these kind of additional packages, for us, it's a quite, so much of benefiting these people who have to wait for longer for some of these packages of care. I wasn't sure what was the question about the national government, whether it is, we're not contracting to ourselves, but generally, again, in South Africa, we still one health system. And in South Africa, we're still using same health policy. But what is different that the Western Cape will find that in terms of improving the health outcomes, the data collection, and you find that will always be listed using their own, not only ours, even their own tool, benchmarking us, that we fare far better than the rest, because we're implementing their policies far better. It's their, I'm saying it's their policy, it's a national policy, but the national doesn't own hospital, doesn't own patients, doesn't own anyone. And for them, as according to the National Health Act, it's about the policy, the standards, and the norms. The implementation happens in the provinces. I'm not sure when we are creating a dichotomy in national, because they don't own anything. All these, they are owned by provinces. All these indicators from the provinces. So I'm not sure exactly what is this. So when they come up, for example, let's say like one that I'm familiar with, which is at the time, I was not a politician, but actually I was a consultant for the national health. At the time when they introduced the district specialist team, where they say in every district there must be this package of specialists. Like you have obstetrician, advanced midwife, pediatrician, and all of those, the package. Which is at the time it was said that this is needed, because at the time we were trying to save the mothers, save the baby, save the children, etc., etc. But in the Western Cape, how they implement it, they say that this is a good idea, but we're going to implement it differently. Instead of having this group of people sitting there, where you'll find that sometimes they get called to go to, if let's say it's a GRD, maybe go to Kanaland and whatever. Rather, let's strengthen the system. Therefore, at the level 2 hospital, have those specialists, for example, let's say at George Hospital, but they can be able to conduct outreaches to those areas so that to strengthen at the local level in those hospitals. Just to make an example, with community health workers, again, whilst there's a policy that talks about the ward-based community primary health care workers, primary health care, something like that. But in the Western Cape, they are saying that primary health care is about multi-sectoral collaboration and public and private, public participation with the civil society part of it. Therefore, we don't want to leave behind the NPOs and the NGOs. Therefore, they should form part of it. So it's the same policy, but we're applying differently according to the context. So there's no competition because they don't own anything, except their role is to get the funding and come up with a strategy for how to fund the health sectors through the National Treasury after they collected the taxes throughout the provinces, and then they come up with a formula because they don't own any hospitals, nothing. Okay, the others, integration, CT, yeah. As you know, that this has been quite a debate that came 20 plus years ago. Actually, it followed after it strengthened after we provincialized the rural health services, that these are the next to come. But as things keep on changing for whether MSC for health and also the mayorship and all of those, these things keep on changing in terms of the moving the goalposts. But everyone does understand that as according to the Constitution, as according to the National Health Act, the health services, it's the provinces that have got a mandate, and it's a concurrent functioning between the national and the provinces, with the national, of course, as the National Health Act focusing on the policy standards and norms, and the municipal health services as those that are also defined as according to National Health Act related to the environment, disease surveillance, and so forth. So we are still having that kind of a conversation, Chair. I'm responding as a general comment. It's not necessarily around this. So where we are now, we were at a space where we did indicate that we'll do in the phase approach, starting with ones where you'll find that we are all working in the same space. I think there were 9 of those facilities. Just making an example, in Nyanga, where there's a city, there's a province. In Olungile, Site C, there's a city, there's a province, and all others, where we say that one sphere must just take over instead of having all of these confusing the patients. And then the other 9, it's where you'll find that there's a lesser than 2-kilometer distance walk, because it means that you are repeating. If you say you've got a clinic A here, clinic B here, but the distance is even lesser and still offering the same package of care. So, and also for me, why is it crucial, this process, again, to respond also to that issue of the overwhelming, where some of the patients sitting on the floor. Why is it crucial for me for this? You get, for example, I just want to make an example of the 2 substructures, Khayelitsha and is it Western, the Atlantis Western. Khayelitsha has got as many of the clinics belonging to the city. I think there are 8, if I'm just roughly 8 or 9. And then for us, we have got Michael Arms, Site B, and then Olungile, which is half-half, and also the Khayelitsha Hospital. The majority of those clinics that are in the city, some of them, they are less than 2 kilometers next to each other. And most of them close at 4 o'clock, 4 or 5 o'clock. And also the packages, it might be 1 or 2, maybe Matthew Goni or Town 2, where they have got Olungile, got the extra package. But they are not 24 hours, except Site B and Michael M and all of the which belong to us. Meaning now, when they offer a limited package of a primary care, which is most instances of the packages that are being offered by the city or the clinics anywhere, it's about the mother to child, which is the baby clinic, the antenatal care, wound dressing, and all of those. And then with a limitation of the chronics for the adults. It's mostly more on children. Yes, they do offer for the adults. But in a situation, just making an example, what we saw in Bothasach, where we'll find that there were fewer now of the people who are in the reproductive age who are utilizing that clinic for baby care. But there were more adults who needed chronic medication, full-time doctor, so that they could have scripts and all of those. But the clinic now, it was offering a limited package. So many of these OMAs and OPAs, without a transport, have to go to Derke Ace in the Goodwood, where they could get this package. It made things quite difficult. It's a similar situation in parts of the Khayelitsha where there's a clinic there, but it's a limited package. Therefore, like you won't even respond to emergency if people are stabbed and all of those, meaning they have to go via. Now, it meant now people either, the adults, they'll bypass it and go straight to the hospital. Because what's the point of going to clinic A with a limited package? Number 2, it's closed at 4. I'll wait until it's after 4 so that I can go to the hospital. Or I got stabbed, where else to go? You go to the hospital. Thus, it puts so much pressure in the Khayelitsha Hospital. Yet you have got as many of these clinics that have got limited package. So that's why if you don't go to Site B, if you are stabbed or short, you go to Michael M, then it means you have to go to the Khayelitsha. And also Khayelitsha, it serves the people of Khayelitsha. That's why in Street A, if someone died, has been sick, will have died in Khayelitsha Hospital. And with Street B next door, will have died there. When they are having funerals, it means you can have 10 funerals in Khayelitsha for same for people who died from the same hospital. And then we said, yo, people are dying in Khayelitsha. It's because everyone is using Khayelitsha. Where else they're going to die from? Compared to, let's say, Victoria Hospital, which services not only the Wynberg and all of those. So whatever happening in Ocean View, who died in Ocean View, other one, maybe in Sea Winds, they won't know because they are different suburbs. It caters for different suburbs compared to the Khayelitsha. So this issue of the reintegration of services, how ideally it's about how can you be able to package this care and reducing all of those, we'll find that there's no need for them to repeat. Probably up like primary school to high school, others up to that level, so that we reduce that burden that is being put in the same hospital. Noting in 2019, 2020, before this budget here, we increased the beds in Khayelitsha. Previously, there used to be either EC, all people with a trauma and everything, plus also with a mental, that needs to be observed for 72 hours, and then everyone, it was like dear Mekar there. So they made sure that now for the psych, for the 72 hour, they need to be removed, and then we created extra beds there for the 72 hour, which is, it's getting full like this every day, up to the level where even where they need to be referred to, if now they are licensed or they end up like being diagnosed that they're mentally ill, it becomes difficult. They added beds for rehabilitation, working with intermediate care, with an NGO, so that for those who need to stay longer, might have stroke and all of those, they don't have to fill the bed there because they need the whole comprehensive psychosocial and whatever. I think there are about more than 15 beds. And then they added even staffing, there was a night nurse and all of those. And other thing that contributed to the whole of this was about people have to wait for their results. So hence they had their own X-ray on site and all of those packages. But some people are waiting for a doctor who might be there in theater busy just to reach in terms of what is the X-ray. It's a similar thing in the Western, in Atlantis. Atlantis has got city, the platform, primary care platform, again is the city. Our primary care platform is MAMRE CDC. The Pella, the VetSense, and all of those, they're under the city. Now with the VetSense, there's a clinic that opens maybe once or twice at the center. There's no clinic actually. Meaning now, one was there, why would I go to the library, that center, for me when I've got whatever? Then rather, let me just go to the hospital. And all of them close. When it's closed, that hospital now end up being reduced, like a clinic. You've got many greens, and yet the staff has to prioritize the reds because it's a hospital. So that's why for me, it is crucial we have this reintegration ASAP, because it puts too much pressure, because when others cannot be able to take off the patients, they end up coming to us. And then I'm the one being told, look at the hospital, college, they're sleeping on the bed. In some instances, just recently, when I was there, there were, lastly, sorry, Chair. When I was there, there were, on that weekend, there were almost 160 mentally ill patients on that weekend alone, which is they couldn't even be accommodated in that observational ward because most of them, they're for 72 hours. And in terms of the act, those patients, they cannot be longer. Those who end up being diagnosed, Lenderia was full. So we have got patients who are competing with the trauma and all of those. And then we've got, it's mostly the young ones, it's non-organic. The young ones with mental symptoms, but they are not necessarily mentally ill, mentally ill. It's non-organic. The contributory factors is about the alcohol and substance abuse. So that's why we keep on saying that mental health services, health services are our business, but health is everyone's business. So in some instances, like in that in Khayelitsha, now some of them have to be given medication where to calm them down whilst they are waiting. And some of the chairs are made of steel. Where do you put them? You can put them in the couches and all of those. But once they are tired in those steel cold chairs, they'll say, can I have a blanket? And then you give the blanket and then they lie down. Same as with the older people. They don't like to sit throughout. So they say, can I just lie down, lie down. So what we discourage people, if you want to take a picture of your relative. Don't take a picture of a patient that you don't even know and then you circulate. We discourage because it's a whole issue about the human rights and the humanity. And also we've got the hotlines where immediately you can send your service at Western Cape government emails and do all of those things that you want to say, or there's a hotline, 06012, all of those. But what we're trying to highlight is that it's everybody's business. The issue of substance abuse and the alcohol are there. I think we're done. It answers the NCOP as well, part of it. We responded to all of those, but we understand that when you're outside, when you see these, health is what makes everyone, actually it binds everyone. Everyone becomes emotive. There's this coalition of sympathy. Whether you are the richest, whatever person, don't use public services. Once you see a patient says that, I haven't eaten anything, and then you put it on the social media, everyone, oh, Aramefoito, do something. So we'll try to explain as much as we can, but we're asking people to assist and meet us halfway. Am I done with the preaching?
Thank you very much, Chairperson. Minister has covered most of it, so I'm going to just go quickly through the ones. So on Member Bakufos, the question about ambulances and also the forensic pathology. We have a distribution of ambulances right through the province. So when you get to the pages that was referred by Member Allen, 49 and the pages after that, you will see that actually our targets in the rural areas is better met than in the metro. So that means we have more, or we have, let's call it better response time in our rural areas than we actually have in the metro. So we have distribution of ambulances, and then the same with forensic pathology, which is being able to do autopsies. They are distributed across the entire province, which means, again, the time that you wait to get an autopsy in a place like Vredendal is not any different to the time that you wait. Actually, in the metro, you wait longer than you wait in Vredendal and in those areas. So the distribution, we can guarantee you, is equitably, and many of our service levels is better in the rural areas compared to metro. When it comes to the operational, I'm going to ask Dr. Karim just to explain to you, Member Allen, the issue about that we have a fleet of ambulances, and at any given time, we have operational ambulances on the road, the difference between the two, and he will quickly take you through what it is, but our proportion of operational ambulances is very high compared to, yeah, so let me not compare with other provinces, but I was shocked when I heard some of the statistics from the other provinces. I thought it's close, but sure, I was really shocked. There was a benchmarking exercise that our DG actually went in Gauteng with EMS, and I was shocked when he sent me some of the details in terms of that. But Dr. Karim will give you a quick description of the operational ambulances on the road, which is at any given time for us is about 250 ambulances, and at any given time out of the fleet, there's a few for repairs, few for this, few for that, but our percentage on the road is very high. If I then come to the race to zero, I'm going to ask Dr. Angelette du Toit, and I'm going to curb her for a time because she will talk the whole day. She's so passionate about this. But it is an innovation, race to zero. You can see from that page that you've referred us to page 67, that it's actually quite remarkable that during COVID and all of this, the number of hospitals that actually came in using less energy than the targets we set for them was exceeded in terms of how the electricity is used, how people are working on saving electricity. And then the water, that's still a continued thing of actually monitoring water use. All of that. But she will explain what the Race to Zero champion is in very short and quick, concise terms. Member Barnes, I can assure you that the Ideal Clinic initiative, I think the minister is right. I sometimes also struggle to understand where it comes from, but maybe we should own some of that as a health department, that there was always this narrative that we disagree with the national department. So I'm not sure why that is still circulating. This team of people here, I can tell you the names of people that they work with in the national department and how well they work with the people in the national. Maybe the national department must say how they experience working with the Western Cape. Maybe that's a different way of looking at it. But I can guarantee you that Ideal Clinic is taken seriously in this province. The Ideal Clinic is taken as a matter of pride by people that work in the primary healthcare system. So, you know, you can ask Ms. Sudumo, the nurses and the doctors and the people working in primary care, they wear their gold status and platinum status and silver status with pride. That is how people are taking this in terms of it. So what you're seeing as a reduction in 1 year is the fact that we had to downscale services in the primary care platform. So you have to now all of a sudden say to primary care, you know, the things that you used to do and give people to come in for their medicines, you have to have people not come to the facility to get medicines. Because you can have people coming with COVID, you have to test this, you have to do that. TB, that you used to get people in to just come and see and take the tablets, you have to find a way of doing it differently. We completely threw the world upside down of what the primary care facility is supposed to do. All of those measures impacts on what you measure yourself against for the Ideal Clinic score. So our Ideal Clinic score is designed for non-COVID times. It is designed for, there's no interruption of the way you render services. And it's based on the assumption that there's no COVID and you do things like we did things before COVID. Now, part of this learning for us is to go back to our national colleagues and say, actually, we need to actually design a system for the Ideal Clinic that copes with things like COVID. And maybe we must be a little bit more flexible about our measures, what we measure, how we measure it, and all of them. And already the national department guys are open to that kind of conversation with us to say, what would you propose? How do we do it? And all of those. So I want to give you absolute assurance. Nobody in this province take Ideal Clinic status lightly. We don't ignore it. And this drop in status from 1 year to the other is purely a manifestation of asking people to do things differently from the full package of care that they had to do. If we then come, and I'll quickly explain to all of this for you, the vitamin A uptake, basically it means that we ask children and a mother to bring the child back to the facility at the regular time slots to come and get vitamin A. Now, can you imagine in COVID how difficult that would have been? A mother is not going to bring a child back to a clinic just to come and get a vitamin A. That's unfortunately one of the things that is, in a sense, something that had to give because of COVID. We are aware of it. We're following it up. We want to get vitamin to children without them having to come to the facility. And we're working on things like that. If you come to the remaining in care for children on ART, actually, if you look at that, the indicator just below it says that of the children that remained in care, that we're still monitoring, their viral load was actually higher in this year. But the issue is, again, remaining in care means you need to be able to come back with your child that is HIV positive to then say, I'm still in care, I'm coming for my appointment and coming. Again, in COVID, that would have been extremely difficult for somebody to bring a child with HIV, maybe COVID in the family, being scared of how to travel, to come to a facility to say, I'm still in care. So we also need to understand that within the context of that. And the last one is the complaints. Now you'll see in the regional hospital and central hospital, those complaints actually were still processed within the 25 days. District hospitals, they are distributed across our entire province. And I can tell you without thinking twice about it, when COVID hit for the second wave, the district hospitals were completely overrun by COVID. Now to still get to, actually I need to spend 25 days to come back to you to, what was your complaint? When did your mother come? When did this? So that I can resolve it in 25 days. It shifted from 90% to 88%. That is the deviation that you see. Within the context of what people were facing, that's the explanation for that. The one with Eden is a very simple explanation, actually. You might recall the second wave was in Nelson Mandela Bay, and the second wave hit the Garden Route. That's the explanation. We had a disproportionate COVID manifestation in Garden Route. It was publicly known to everyone that between November, December last year, Garden Route was severely affected. That's the over-expenditure in terms of that. Member Windvogel, your question on the city is right, and I, as an official, will say to you, as an official, our position in the health department has been for many years that the services in the city of Cape Town should be rendered by the provincial health department. It will allow us two things. It will allow us the question that you have, that we can consolidate. The minister explained exactly that we can work out in Khayelitsha what's the best way of providing consolidated clinic services to all the people in Khayelitsha in such a way that we protect the hospital for people to present. But that means the full package of service, and where need be, a 24-hour service. The City of Cape Town has limited package of service, no 24-hour service, no weekend service. So from our perspective, it should be under the Provincial Government Department. We can do it better if we consolidate and use the resources wisely to get better outcome in terms of that. We've got an example when we did that in Grassy Park. That was about 5-6 years ago. We consolidated 3 clinics, 2 city clinics and our facility in one new facility in Grassy Park. That new facility costs less than the 3 cost before. And that new facility renders more patient care to more people than it was before. So that's a classic case. We had a Botasig example. Similarly, when we took it over from city, we render more and we spend probably the same or less resources by getting more impact in terms of it. So the case from the officials is a very clear case that we believe it should be under one authority. I think in terms of the intermediate care, I'm going to ask Ms. Arendse just to reflect on that. There is 28 intermediate care facilities across the entire province. Again, like EMS and FPS, we have intermediate care facility in every district in the province, and people have access. So that 28, I know there's a small proportion of that is in the metro, but the balance is in the rural, and that 1,148 beds you're referring to is distributed through the pump. So she will just give a quick update of where intermediate care is. And then in terms of, I think Member Van Vogel, the Minister answered the NCOP oversight visit issue. I would just like to add, I mean, the last time I was at Khayelitsha Hospital, I was taken aback by the fact that we have more hospital beds now than we had before. And I was struck by a statistic, which I thought, wow, that measure is such a good measure, is that if you're in Khayelitsha Hospital today in the metro, your time to getting a CT scan is faster than in any other hospital in the metro. Because there's a CT scan, there's a radiographer that can take the CT scan, and you can get your diagnosis without having to get into an ambulance like in Mitchells Plain and driving to Groot Schuur and wait to take a CT and come back. So there's many things about Khayelitsha Hospital's care inside the building. That's actually one of the better measures that we have in the metro. There's an unfortunate association with Khayelitsha Hospital that people believe there is poor care. Therefore, when people come to Khayelitsha or want to visit, they want to see the poor care. And it's visiting the place until they can prove there is poor care. As a management team, we are a little bit exasperated in how to respond to all the visits, all the complaints, because we can guarantee you there is good quality care provided in a facility. The issue is what Minister Mbombo is saying. What the facility faces is the overwhelming societal pressures that plays itself out in the context of Khayelitsha, which is actually a whole of society responsibility of how to curb the impact of of alcohol on weekends and month-end weekends specifically, and then the impact of substance abuse on young people in terms of these psychotic episodes presenting in the facility. So there is a call to arms that everybody works together to try and prevent and shield the hospital so that the good quality care that is there can be given to the people that really need it and when they need it in terms of that. When we then do the Klipfontein, Mr. K did raise the issue of Klipfontein. So the Klipfontein issue is one of 3. So we have Klipfontein, we have the Belhar Regional, and then we have Helderberg. But Klipfontein is prioritized. So the reporting period that we're talking about is that a tender was open and the tender was considered during that so that we can get the professional services. And that is to start designing the building and sign it off. There was the right word would be a objection to the process, and that has resulted in the process, the tender could not be awarded. So what has now happened is a new tender has been placed, we have a new time schedule, and we're obviously doing everything we need to do with Public Works and everybody in our power to get that building on the ground as fast as we can, Member Van Vogel. So we have put all our energies and efforts together with Transport and Public Works to fast track that process, together with Tygerberg Regional, and together with Helderberg, because it's key projects that all of us would like to see to come to fruition. Then specialized hospitals. There is no specific plans from us to increase specialized hospitals. The reason why we say that is that we believe, for instance, like mental health, a lot of the issues, as Minister Mbombo described, is that we need a whole of society approach to deal with the issue of mental health. Building more psychiatric hospitals is not necessarily the wisest way to deal with mental health. So therefore, again, through Western Cape government, mental health has been prioritized, and we want to do a whole of society intervention across departments to address mental health. Then the last one is, obviously, we have hospital care, and I said previously about the staffing. The distribution of staffing that we have, there is a mechanism that we have. It's called an APL, which is an approved post list. We have an approved post list per hospital. That approved post list gets updated monthly by Mr. K. And we know exactly at any given time which specialist, which nurse, even by name per hospital, which post is filled, which is vacant, which is in the process of being filled. So we have all of that detail for all categories of staff across all our hospitals. Dr. Karin, Dr. Angelita Tue, and Ms. Arendse. Thank you.
Thank you very much, HOD. Can I please ask officials of the department, I'm just having a look at the clock, if we could perhaps wrap up the response, say, by 20 past, please. Thank you.
Thank you, HOD. I'll be quick, Honourable Chair. Just the EMS vehicles. I think it was Member Allen that asked the question. So in total, we've got about 550 operational vehicles, but that includes ambulances, the rescue vehicles, as well as the health net. And out of that, the subset, we've got about 250 operational ambulances now. You asked the question about maintenance and downtime, and obviously out of the 250 vehicles, a proportion are in for maintenance, in for downtime. So out of that, we roughly have about 85 vehicles that are on the road, and that's split between metro and rural. So that's the high-level numbers, Chair. 550 total vehicles operational, 250 actual ambulances, and then about 85 vehicles that are on the road, split between metro and rural.
I will be quick. We are looking at becoming a net zero provincial department by 2050. So we are trying to mitigate the climate change and reduce the emission. So this is a race to zero. But in order to do that, we need someone, and this is a champion, that it doesn't exist in the current organogram as a post in DPSA. So together with our colleague in people management, we are trying to create this champion that can coordinate and report and provide the monitoring on what we want to achieve by 2050. So it's a long plan, but it's against the mitigation of climate change. Thanks.
Thank you for the question on intermediate care facilities. So out of our intermediate care facilities is basically to transfer payments to non-profit organizations. Like we said, 10 of them are based in the metro, across the metro, and the balance are based across the rural. The acuity of the clients are mostly subacute care, respite care, which is relief for the family, and mostly palliative care patients as well as end-of-life care. So that also gives us a picture in terms of why the profile of the patient looks the way it does. Thank you.
Ms. Arendse speaks a bit fast, Member Mpogo. 10 in the metro, and the rest, 18 in the rural districts of those intermediate care facilities. 10 in the metro, 18 across all the rural districts.
Thank you very much for the response. Members, we now formally conclude Part B of the annual report. We are now with Part C, which deals with governance, pages 101 to 114. Are there any member that wish to pose a question? Yes, it will also be dealt with in SCOPA. Then shall we move over to Part D, members? Human resources. Page 117 to 156. I recognize Member Botha, Member Baku Vos, Member Barnes, and Member Van Vogel. Please proceed, Member Botha. Thank you.
Thank you very much, Chair. On page 134, reasons why staff resigned during this reporting period. And I just wanted to check with the HOD, the type, nature of work. What would that be? And then on page 151, I think, let me just make sure, 151, yes. 151, there's those grievances. And I just wanted to check what would types of grievances be. And there is grievances resolved, and I see the definitions of it in the notes. But I just wanted to check just what is the content of it. And then on referring back to page 134, there's that 57 number, personal grievances. Would that 96 or 69, would that be part of it? Is that sort of, does it cross-reference each other? Thanks, Chair.
You Member Baku Fos. Thank you, Chairperson. Mine is on 117. On the occupational health and safety. Does the department have a danger allowance policy? If so, what are its content and how does it apply to COVID-19? What does this OHS Act apply to COVID-19 and those employees that contracted the virus in the line of duty? That's my first question. And the second question, Chairperson, is on the status of human resources in department, page 118. Is there a specific reason why 11% of the workforce is not permanent, and which positions are in this 11%? And my last question is on page 1182. On the SMS breakdown, why is the percentage of Africans, particularly females, so low? What is the race profile of the persons employed to fill the vacancies that existed in the organogram? What are the plans to attract more Africans to fill existing vacancies in the senior to top manage? As a resolution, can the department appear before the committee early next year to give a presentation on its employment equity targets and how it plans to recruit more? Chairperson, this will be the last one. It's 118 bullet point 6. Can you provide clarity on this in relationship to the 89% employed in permanent capacity mentioned above? Thank you very much, Chairperson.
Thank you very much, Member. The very, very last of the last. Thank you, Member Barnes, and then Member Van Vogel.
Thank you, Chair. I'll be shorter than a miniskirt. I'm on page 119, People Management Priorities for 2020-2021. It's saying it is easy to understand how staff working at the coalface can become mechanistic in the way they perform their tasks. Chair, what I want to know is that what is the update on the transformed organizational culture and how has it addressed the bad attitudes and the treating of patients? That's my first question. My second question is on page 125, first bullet point, leave quarantine and isolation. What I want to know there, Chair, is that what were the guidelines regarding leave, quarantine and isolation for frontline workers, particularly nurses who complained that they were forced to work despite their colleagues contracting the virus? My last question, Chair, is on page 126, financial challenges. The personnel budget is not sufficient to fund all posts. My question there is that what is the number of posts that are needed and how much additional budget is required for that? Thank you, Chair.
Thank you very much, Member. Member Van Vogel and then Member Turgo online.
Thank you, Chairperson. Chairperson, mine is on page 119, last under scarce skills. What are the plans to convert these positions into...
Excuse me, Member Van Vogel, can I just please ask you to just speak up a bit, please?
Oh, sorry.
Thank you.
Yeah, Chair, mine is on page 119, last under scarce skills. What are the plans to convert these positions to full-time basis? Then also page 119, if we can get an update regarding cases under labor relations, it's under labor relations. If we can get an update regarding cases of doctors that steal broken chairs and the issues of nurses that were fired wearing wearing a gallet finalized what? I'm not sure. There was this dispute about nurses wearing stuff that they are not supposed to wear. And then the last one, Chairperson, is the Barrett Value Survey. What I want to know there is the highlights of some of the key highlights from this survey. What are the levels of staff satisfaction as per the latest survey? Thank you, Chairperson.
Thank you, Member Turgo. Are you there, Member?
Yeah, thanks, Chair. Yes, Chair, I'm there.
You may proceed, Member. Thank you.
All right. I'm on page 131, Chair, under the table titled Employment and Vacancies by the Critical Occupations. In each category there, the number of filled posts is lower than the number of funded posts. I just want to understand what could be the reason behind that. And then the second question is on page 132, where we see that employees whose salary positions were upgraded as a result of upgrading their posts for the years under review. Does that mean there is no growth there? What is going on there with the funding of the upgraded posts? And then on page 134, under the table, staffing leaving the employ of the department, there is a high number of resignations within that the department, with a total of 1,292 employees resigning. Then what I want to understand there is that is it the doctors or the nurses that resigned, or what categories are there? And then what is the department doing to keep the skilled employees within the department? On page 5, there is a table titled the promotions by salary band. Out of the 3,020 lower skilled employees, only one is promoted. And I need to understand what is the promotion plan of the department as far as that is concerned, and what is the reason behind that. And then lastly, on page 137, on the table, employees with disabilities. For years now that there has not been any employees with disabilities on top in terms of senior management positions. Want to understand what could be the reason? Is it that result in the department failing to source people with disabilities? Thank you very much, Chair.
Thank you, Member. Minister Mbombo.
The department can start.
Thanks.
Thank you very much, Chairperson. So I'm going to go very quickly, and then I'm going to ask one or two of our colleagues just to come into this. So on the issue of reasons for resigning, so I just want to make that very clear, that the reasons of resigning is, if you read the table properly, half the people say they don't give a reason why they resign. The other half tell you these are the reasons, and then there's a subset of people that says personal grievances. So the issue is, it's a small proportion out of all the people leaving our organization. It's 67 cases, and it is about personal grievances. So that is a group of people that basically said, well, I'm leaving because I'm not satisfied. I had a grievance, I had a problem with this one, a problem with that one, and I'm moving on to others. That's That's what that specifically means. When it comes to the actual grievances and the types, Mr. K has got a little bit more detail. I'm going to refer to him, then he can give you just an overview of the grievances and the types. I'm going to then, Member Baku Vos, the issue about danger allowance. There is a specific dispensation for danger allowance. Again, between Mr. K and Ms. Shade, they can then refer specifically on what is our dispensation around danger allowance and specifically what category. So you must understand the danger allowance and COVID-19 doesn't necessarily coexist. It's danger allowance is a specific dispensation. As the minister says, that gets negotiated in the chamber. So there's the link between that and COVID is not, there's no link because nothing has been negotiated in the chamber in relation to that. And therefore the occupational health and safety issue, again, Mr. K can then give you a sense of our occupational health and safety issue as it relates to COVID. Because from our perspective, we use this whole Occupational Health and Safety Act to really look at all our responsibilities as an employer because of COVID. So that is the issue that Mr. K will just quickly touch on. I think the issues of contract appointments, Member Baku Vos, we have addressed that in the first part, where I explained that many of the contracts are people that's interns, that's doctors, that's short notice, and contracts that we added on top for COVID. It's exactly the same answer to that question. And then the issue about African male and African female low representativity in the senior management cadre. So again, our recruitment selection policy is a deliberate and intentional one. And the reporting period has got the numbers. We are specifically looking at addressing the issue of representativity in senior management in the way that we do our recruitment selection process. If I'm going to go then over to Member Barnes, I think Member Barnes, your first question is an excellent question and something that we grapple with. And that is, what is our journey on our organizational culture? Again, I would like Ms. Shade, when we have that, she will give you a quick, and again, she will get very passionate about it. So she will give you a short answer in terms of what our journey is to work specifically with a social compact with our frontline staff in terms of our, let's call it our change journey of how our frontline staff bring themselves in how they actually engage with staff, with patients and their families. Then in terms of quarantine and isolation, there were specific guidelines. So Mr. K, when he responds about the issue about what we did during COVID, there's specific guidelines that we followed. And it is guidelines that actually came out of the Ministerial Advisory Committee. So we followed guidelines as advised by the scientists. And that is the guidelines that we followed in terms of how long people should be quarantined, how long people should be isolated, when should they do testing, when they report back to work. And that was very strictly followed, as far as I know, in terms of everyone. And we work very closely with organized labor whenever people complained about that, but he will explain that specific guideline issue. And then the question you ask, which is probably a very difficult question, I'm going to give you a very high-level answer. If we say that the money that we have is not enough to pay for all the staff, and the question you're asking, so how much staff do we need and what budget will that require? That is internationally, it's a very difficult question to answer. Because you don't render any healthcare service, even if you are in the United States or in any first world country in Japan, that people will say, we have enough money to employ all the people we need to employ to be able to deal with all the healthcare needs of a population. So it is an extremely difficult question internationally. The reality is you render healthcare services with the resources that you have at your disposal, and therefore you have to make tough choices. Doesn't matter where you are in the world, in terms of what's the best way of deploying those resources. So Member Barnes, there's not an idealized answer, because we, what do we say? Do we say we're a first world country and we would like everybody that comes in to have a service within 2 minutes and have this, that, and the other? It's unrealistic for our context. So it's a difficult question you're asking. And for our making sense of it is the resources that we have, we need to work within the resource envelope to do the best with what we can in terms of the people that we have to do the best outcomes that we possibly can achieve. That also lies under the whole principle of universal health coverage, which is what people do in all countries have done well. Like I had a trip with Minister Mbombo to Thailand, and you see how they do it. The UK is different, Turkey is different, other countries are different, but everybody grapples with the same issue. What the resource you have, what's the best possible use of the resource, rather than what do we need and how much it's going to cost us. Because internationally, virtually nobody does those calculations anymore. If we then go to Member Windvogel, the scarce skills issue and moving towards permanency. So I'm going to ask the colleagues from HR, when you deal with danger allowance, also with scarce skills, and what is our approach in terms of that? There are specific categories of people in scarce skills. That's extremely difficult for us, and there's a strategy of what we want to do in terms of that. Then I think the two cases you're talking about, specific cases, and again, I think we shouldn't be disclosing the individual details of specific cases, but just to say to you that the case that you're referring to about nurses being disciplined for not wearing gilets, and then the case of doctors being dismissed because they took a chair home at Tygerberg and they were disciplined for taking the chair home. Both those cases has got a process internally. The minister is aware of both of those cases, and the due process has been done, like with all other cases, for every single person affected by that. We followed due process. The chair issue was resolved internally in the department. The issue with the gilet went externally to the department, went to the Public Service Commission. You know, so each individual person's got the right to take it through the entire process in terms of that. I think the Barrett survey, the highlights, if I may be so bold to give you that, is the highlights is that the measure that we look at in the Barrett survey, which is called an entropy level. Entropy means the higher the number is, the higher the discord is or the disjuncture is. So we dropped as an organization from the previous survey to this one that we reported on 4 points or 3 points, which is a huge improvement. So it means that if you have less and less entropy, you have more and more alignment between the people's personal values and whether they find expression that their personal values is met by the workplace. So that means there's an alignment between what people believe they stand for and what they can express in the workplace. We're very proud of the fact that that entropy dropping is a sign for us that the culture is improving. The question that Member Barnes asked, because that entropy level now, and there's certain places in our department where that entropy level is dropped to below 10. Now that is almost like unreal. That's like a harmonious workplace and everybody's happy to be and they come with a smile and they can't wait to get to work. There's many places in our department actually has entropy levels less than 10. There are some where it's slightly higher, and in those places there's a concerted effort to increase the culture so that the entropy level can drop. So that's the main thing. The second thing we look at is then what is called matched values. And matched values, if it is 6 or 7, it's 6. It is very good because basically it means what I hold dear as a person and what the organization holds dear as a person, there's a match. So it is a fit, what we call a culture fit. Those are also high figures in terms of the highlights of the Barrett survey. If we then go to Member Kleko's questions, I think the filled versus funded post is a technical question that Mr. K, if you can just quickly amend it out. That's also linked to the upgrading of posts, and then the resignations, promotions, and I must be honest, the last one, disabilities. So the resignation and promotion, we will kind of just quickly explain what's in the table because it's technical questions. And then the issue of disabilities, I can just maybe, our colleagues can maybe just reflect on disabilities, but I know the last time we had a discussion on this, one of the key difficulties is for your disability profile is the person with a disability must be willing to disclose that I've got a disability. So that is actually quite I think the team pointed out to us that there's many people that has a disability, but they're not willing to disclose I've got a disability. So there is a context of us being very cognizant and we're driving and we're constantly asking and constantly looking. But there is an ongoing process in our department to take disability serious. So, Chairperson, if we could just ask the members to quickly respond. There's mainly Mr. Kay and Ms. Shade. Simon?
Thanks, HOD. Thank you, Chair. I'm going to kind of paint a little bit of a picture so that things fall apart or come together from a staff safety and a staff wellness perspective. Because, I mean, COVID taught us the critical nature of occupational health and safety and the elements of occupational health and safety. So the first thing that we did was we put PPE on everybody. And then we realized, but hang on, we actually need to do risk assessments. So then we did risk assessments on every single person. And where you came out in terms of your risk assessment is where you were then placed. So people that came out with really high risk assessments, so in other words, age was a big factor, comorbidities and things like that, you were taken out of the front line. Those that weren't at high risk were left in the front line. But obviously we would then had to mitigate to make sure that we were protecting people. So we were providing the PPE at that point in time, and we're still doing the hand sanitizing and the cleaning and all of those other bits and pieces that really impacted staff. But that was kind of, I guess, our first way of learning around the occupational health and safety. And that impacted things like the Q&I. So the Q&I then, it was quite rigid. If you tested on day 3, and then you had to test again on then there was confusion that was created, because then you had to test again on day 10, and then it was revised back to day 7. So there was a lot of anxiety that created itself. And there were issues, and a lot of the grievance, a lot of unhappy staff were because I thought I understood what was happening, but now seemingly the science has shown and the rules and have changed somewhere along the line. And that, I think, led to a lot of anxiety. That led to, I guess, some level of grievances. I mean, the grievances are recorded and dealt with in terms of process. But we needed to kind of address the raw human emotion that found itself present, particularly in the first wave. And in fact, I remember the anxiety levels and the unhappiness and the discomfort were very high until about, I would say, July, August, where things dropped off quite considerably. And then we hit the next wave, and then we had to change a little bit because it hit us so hard and so fast. We just lost so many people. We lost 56 people in December and another 26 in January. And everybody was just completely shell-shocked. It was this wave just overran us. And we couldn't explain it. People were just, they were numb. And that's when we went into a process of intentional grieving. And we said, whoa, it's okay to cry. It's okay to express exactly how you feel, because the person next to you is feeling exactly the same. And that was a critical journey that we went through within the people management space. Because at that point in time, we also said, but hang on, we don't know how to deal with grief ourselves. We need help. And so we arranged for structured and informal sessions where people would then come and debrief. We had a series of, I think it was 44 grievance sessions where we had between 200 and 300 people on those calls every time. We shared, and that really, I think, brought us together. Because the questions about the culture of our organization, our leadership journey, I tell you what, COVID amplified that. The fact that we are so interconnected and that we need to be able to acknowledge and address our feelings. And that was incredibly powerful. And that's why you will see that then a lot of the volumetrics of things like the grievances and the like then came down quite significantly. I think most of the other questions I'll ask, because they're a bit technical in terms of the tables, But just once again to reiterate what Keith said earlier, we are very clear on process. So we understand that if a grievance is lodged, or if there is an OSD query, or there is a scarce skills query or a danger allowance query, we understand very much the process that must be followed to its logical conclusion. Whether that is within our control as an organization, or whether it must go somewhere else, we will follow that. We will follow that through, and we're quite proud of that process, because we know that people are going to be treated fairly and equitably all along. And when we see the statistics, we know that the output of that or the outcome of that statistic that we're reporting on is correct. I do just want to talk to the equity issue, because it is very important. And there has been, as we were talking about people that don't want to disclose disability, a lot of people have looked into the Western Cape and said it's closed, we don't want to apply. Something has changed, and for the good, because now we are getting candidates of exceptional caliber who also happen to be Black African candidates. And therefore, the doors have opened. And within the last, I would say the last 18 months, we have probably appointed 6 or 7 primarily Black African female senior managers into our organization. And that was because, not because we were focusing on we were focusing specifically on it, but maybe our interventions to achieve the desired outcome were different, because suddenly the door opened, and suddenly we had actual applicants coming through. Now, you can't employ somebody if there's not an application. You've got to take that person through the process. I mean, you're aware that particularly within the SMS caliber or cadre, well, in fact, all cadre, but particularly in the SMS cadre, it's quite a rigid and quite a strict process, and there are multiple checks and balances that come into that space. And so just because of the change in the culture and the perception of our organization, so we're going in the right direction. And I think that's something that we're really, really excited about, and we'll continue with that journey, because once again, once you just open the door slightly, the doors open much wider, and we've seen a lot of that happen. But I'm going to ask Ray to answer some of the more detailed questions. Thanks, Ray.
So I think maybe just the first one, just to pick up on the danger allowance, because there was a question that was posed. So as HOD correctly said, it is a collective agreement, so it's nationally determined. So in particular, there are 2 categories of danger pay. There is the standard danger pay allowance, and there's also special danger pay allowance. And I also just want to say, these are things that are determined against the nature of the work and the nature of the jobs. And so obviously these are applied discretionary in terms of it. The particular categories that has been covered in the collective agreement would be our forensic pathology. As you well know, they are the most exposed, and in particular in the pandemic, we knew that, as well as the EMS. And we know that especially our EMS staff, they've been quite in the front line, and they faced a number of things as they've executed their duties. So that would be another category. And then there's also specific categories with our nursing personnel, in particular with areas such as psychiatric wards, where they are exposed as well. So this is sort of the status quo. We comply to this, and this is sort of where the status is. I hope that answers the question. And then I maybe just want to respond particularly to before I actually ask Andre to speak to our scarce skills interventions and our approaches, in particular with the organizational culture journey and what's been transpiring. And I think there's been a long legacy in the department, especially over the last 10 years, of really understanding where we want to be, and in particular aligned to the UHC. So from there comes very many ideals, and one of the ideals is how we want to show up through our leadership process, how we actually want to be within the department. And in particular, we also monitor things like the Ideal Clinic, and we look at these things not in isolation in order to get a sense of it. So our culture has transformed, absolutely, most definitely. We even have metrics into exact moments when our culture has actually shifted on. So it's shifted for the positive, and in particular, I also just want to sort of elaborate a little bit more on the measurement side of it, in particular with the Barrett Value Survey. We had 7 value matches, and I just want to read the values to you. The things that our employees have started to resonate so strongly with, that they really bring their whole selves. And I think I've always said that our department is spoiled. We're spoiled in the sense that our staff are passionate about what they do. But the values that really came out quite singingly in the most recent survey has been, they see teamwork and they recognize it. And I think that's evident in our pandemic space as well. We've got a very strong accountability and oversight. Today is one of those examples where we can actually really go there with all the committee members. Very caring, that comes out more than anything else. Respect is something that we've been working on for a number of years, and we've gotten there. Responsibility is something that our staff really take very seriously. They see us as leadership being responsible and responsive to them, and likewise, in turn, they would then hopefully show this to our staff, and I think they are. Quite committed. I mean, that's something I don't see very often transversely in surveys of this nature, that commitment will come through, as well as honesty, and we've really held that one as in high regard, because people wanted us to be a little bit more transparent and speak more to our staff. Our journey has been an eclectic mix of a number of things, including executive coaching. We've done group debriefing. We've really had lots of team cohesion sessions, and we've ramped that up more in the last couple of years. How this transpires into the front line is quite important, because we're now not afraid to really answer the public. We've gone there, and our staff is actually connected to families. Contact tracing was another example of how we took the care and the time to really listen to people's stories about the pandemic. So I think we've been very well positioned. We've taken this on, and I think our entropy has really come down quite a bit, and I think we are on the journey of transformation more than anything else. If I may just ask Andre to speak to the scarce skills matter and respond to that accordingly.
Thank you very
Rekhana.
much. May I ask that is it possible to wrap up in the next 2 minutes?
Thank you, Rekhana. Thanks, Madam Chair. Very briefly, in terms of the scarce skills, we regularly do a scarce skills analysis by looking at the supply, and the supply being the number of bursaries that we offer in terms of the scarce skills categories across the health and allied services. We also look at the attrition rates over the previous 4 years, and the difficulties in filling posts within the 90 days. We also look at the potential retirements and compare that to the actual retirements over the previous 4 years, the potential retirements going forward. And from this, we obtain a good picture where the scarce skills lie. And primarily the scarce skills are within our nurse speciality categories, but as we've also indicated, there are also scarce skills within our sonographers, radiography specialities, forensic pathology specialists, and then in the engineering and technical services engineers, and also medical case managers. Thank you.
Thank you very much. Members and department, at this stage of the meeting, we would have asked members of the public, if they were present, to pose their questions and for the department to then respond. In the absence of any members of the public, I will now ask the Minister and the HOD to please do their concluding remarks, if possible, in 2 minutes, please. Thank you.
Thank you, Chair, and also the honourable members for giving us this opportunity as a department to present our case on the annual report of the previous year. And also thank you for the questions and us to remain on our toes with all the answers that you require. To the department, thank you for being there. I wasn't expecting that there are so many people who could come on hybrid, because most instances some of us were on virtual. But again, as Dr. Kluti indicated earlier, we are not here leading ourselves. We are here representing all other 30-something thousand people that are out there, and also with the whole population of the Western Cape. We are not perfect. We are human, but what matters, what lessons we learn from that aspect. So we might cross each other in some instances, but we don't take it personal. So thank you very much to the staff. COVID is not over yet. We are hopefully that we'll be able to vaccinate as many before the fourth wave, especially the over 60-year-olds where the challenges are. As we have been calling out that this pandemic, it requires all of us. We are the last line of defense. The first defense is there in the communities, which is anyone else could be able to tackle this prevention before you even go to get a ventilator by us. Thank you to the team. And then lastly, for those all who lost their lives, specifically from our staff from the COVID, we still remember them. With the soldiers, they will always encrypt their names in some of the stones, but for us, their names are always in our heart. Thank you very much, Chair.
Thank you very much, Chairperson. Just allow me to, if I can just thank the committee members. I know that this past year has been a difficult year for everyone. So I personally would like to commend every single member of the portfolio committee. I've actually had the pleasure of engaging probably with each one of you on numerous times over the last year. So I want to commend you for your understanding. I know, like Member Barnes, you contacted me in a very difficult time. Member Windvogel, you contacted me. Member Baku Vos, everybody else, Member Allen, Member Botha, and Chairperson Philander, all of you have contacted me. But I just really want to thank you all for your understanding, your compassion, and really for giving us the space to be able to do what we do. So it's really good for us that we have that level of respect, that level of communication between us, and that level of common understanding that we're all doing this in the best interest of the citizens of the Western Cape. So I really want to commend you for the manner, the mature manner in which we're able to engage and for you to actually do your oversight role. But I really, really appreciate the level of respect that you show in the way that you deal with us as a department. So we're very fortunate in our engagement with you. And then the second thing I would like to say to Minister Mbombo, it's really been very, very good for us. And I've always said it, and I've shared this with her a few times, that we're very fortunate to have her as an MEC. And her humanity and her commitment to the people of the Western Cape is something that kept us very strong in our darkest moment. You heard Mr. K talking about our darkest moment, which was December last year. And we're always eternally grateful for her in the manner in which she supported us. And she knows what I say when I say this, between Christmas Eve and the 3rd of January, when she had our backs, she did what she needed to do to help us. And we really are really thankful for her. But lastly, I couldn't be sitting here, and I'm incredibly proud of the people that's sitting around us. You can also see the pride that people come to and take this seriously. And Mr. Dumo drove all the way from Mossel Bay to join us. Thanks.
Thank you very much. Members, thank you so much for your indulgence in this meeting this morning.
Chairperson, can I just say one thing? I was going to end up on a light note. And I say, while we were sitting here, Member Allen, our provincial data center confirmed that the 9.6 million contacts was for 2.5 million and 41 patients that came to our services. Thank you.
Thank you very much, HOD. Members, thank you for your indulgence. You will stay behind. We still have some business to conduct. Allow me to say that in acknowledge of the vast impact of COVID-19 on the healthcare system across the world, I want to echo the sentiments of every vote of thanks and accolades expressed to the department in this committee today. Constructive engagement through the oversight here at Parliament and conveying information to the public. It speaks to the unwavering efforts of each and every official and medical practitioner that help reimagine the system to respond to COVID-19 whilst maintaining other essential healthcare services as well. As we deal with other parts of the annual report in the next session, I wish to further acknowledge the governance and financial matters that directly impact the level of services, and therefore I want to congratulate the department here today on their performance despite the pandemic. 75% of the population in the Western Cape is reliant on public health services, to which COVID-19 may have extended the coverage, yet it remains community to continuously improve. It remains your vision and your mission to continuously improve. And we thank you for that. I think from my time here at Parliament, I have not engaged in a session like this before. Today was extremely special, and one could really capture and see and experience what has gone into this department, what you have done this past year under very, very difficult circumstances. And for that, we are eternally grateful as a committee and people of the Western Cape. So thank you so much. Be blessed, be safe, and please continue with what you are doing. We really appreciate all of your efforts. I will now excuse you, Minister, the HOD, and every official. Thank you for coming. So we wish you a safe journey back to Mossel Bay. I wish I could go with you. And you are invited for lunch in the members' lounge. You are now excused. Thank you very much. Wow.
Chicken gain weight to this one. Shall I lost a lot of weight? Dr. Dutoit. Dr. Dutoit lost a lot of weight.
And Bombo gained.
Then, yeah. I have ramen. Ask if they have any resolutions or findings or whatever.
Thank you very much, Member Botha, and that is most certainly appropriate. I think we can all agree to that. Thank you so much. Member Baku Bakufos, any recommendation from your side? Your Member Botha will inform us now what that was about. Apology accepted, Member Baku Bakufos. Things happen sometimes. Member Barnes? Yeah. Thank you very much, Member Barnes. Member Botha?
Chair, if you will allow me, I want to latch on to what Member Barnes is saying, and I want to say that we could, as a committee, have a special motion printed from this committee to him. We can request of the Speaker's Office to have it framed, and then also from this committee, through our committee coordinator, we could perhaps purchase a set of cufflinks downstairs and then send that on to him as appreciation.
Okay. Sure. Members agree? Thank you very much. Thank you, Member Botha. Member Van Vogel? Yeah. Yeah.
So ons het net mats het sy nooit happy with everything. Ek is moet onthou.
Yeah.
Hy acknowledgement gee dat hy in die short space of time dat hy
Yes.
since he becomes that
Yes. And unprecedented times, we've never experienced a pandemic of this sort, but he steered the ship. Thank you very much, Member Van Vogel. Member Ellen, are you covered? Thank you so much. I'm covered as well. Namonde, is there any business that we should take care of before we... So members, we are officially done. Thank you very much once again for your indulgence. Member Barnes. A slow motion. But you know, this is really something, but I'm not sure how your process worked in terms of allocating to a specific committee, but I just find that we gel so much because ons harte klop dieselfde. We've got the same aim and vision at heart. As much as you said, Member Van Vogel, we can disagree on certain things, but we can also agree on many things. And that makes it very special to work with all of you. Thank you very, very much, members. We see each other at 2. And now we can have lunch in the members' lounge. Member Kego, you are not invited. Thank you so much.